So we welcome you all to the webinar on Nuances in Ovulation Induction in PCOS, organized by IFS SIG PCOS in collaboration with IFS UP East Chapter and Infertility and Endocrinology Committee AOGD. Convener for this SIG is Dr. Neeti Tiwari, and co-conveners are Dr. Neelam Bapna and Dr. Parulkar. Dr. Picky Saxena is the chairperson for the Reproductive and Endocrinology Committee AOGD, and Dr. Malvika Mishra is secretary IFS UP East Chapter. So now I would request Dr. Neeti Tiwari and Dr. Picky Saxena ma'am to kindly give the welcome address. Dr. Neeti Tiwari is Senior Consultant at Center of IVF and Human Reproduction, Sir Gangaram Hospital, and is also the convener for this SIG.
Good afternoon, everyone. So here we bring now the second webinar from the Indian Fertility Society SIG on PCOS. And this webinar is directed very specifically to ovulation induction in PCOS. Though we know that ovulation induction is the first step when we begin with treating infertility in patients of PCOS, but it is not always easy. And sometimes we come across tricky situations. So we'll be discussing that also in our panel discussion at the end. So please stay till the end. We have a lot of experts on the board, and we will be discussing something which we encounter in our day-to-day practice. And I'm thankful to Dr. Picky Saxena, who is the convener with me in this CME, and for joining us on behalf of Reproductive and Endocrinology Committee AOGD, and Dr. Malvika Sabharwal, who has given us the opportunity to collaborate with the UP East chapter in organizing this webinar. Thank you so much and welcome everyone, and we look forward to a great discussion. Please keep on posting questions in our chat box so that we will try to seek answers amongst ourselves. Thank you so much. And now over to Dr. Picky.
Thank you, Dr. Neeti, and I welcome everyone on behalf of the Infertility and Reproductive Endocrinology Committee of AOGT. And I think it's a very nice collaboration that we are having with SIG PCOS. And PCOS, both infertility and general gynecologists all have to deal with, and it is really challenging. Sometimes the effect of ovulation induction will not come, and on the other hand, rated response. So we have expert guests and the guests of honor, Dr. Pankaj Talwar and Dr. Ashok wanted to join, and they have sent the best wishes, but they are in fact traveling, so they will not be able to join. So I welcome both of you, Dr. Indu and Dr. August gathering. Thank you. Dr. Indu ma'am.
Thank you.
Madam is the Vice President of AOGD, and she's a professor and a very senior sought after consultant at RML Hospital. So over to you, ma'am.
Thanks, Picky, for the kind words, and I feel honored and privileged to be invited to this webinar in which you are focusing mainly on PCOS and infertility. So thank you very much for the invitation. Thanks, Neeti, Picky, and the whole team for taking up a topic like PCOS. As we understand, is very complex. Not only in diagnosis, it has multifaceted problems, and when it combines with infertility, it becomes a problem. So, though if we look back, we have come a long way. If we look back 20 years, we have come a long way in making the diagnosis. We have precise criteria. But when it comes to treating infertility, we still face problems. We are knowledgeable, but there are still gaps in having knowledge and applying it to the patients. So it's only through these discussions that we can discuss and come out with some meaningful things. So I'm looking forward to a very useful and meeting. And thank you very much for inviting me.
I would now request Dr. Shweta Mittal, ma'am, the General Secretary of IFS, Senior Consultant at Center of IVF and Human Reproduction, Sir Gangaram Hospital, to say a few words.
Good evening, everyone. And it's a wonderful program, what I can see, and very nice association of, three, I would say, very strong, forums coming together, AOGD and UPR East chapter and SIG. So thank you, Dr. Neeti, Dr. Piki, and Dr. Malvika for making a very practical, I can say. I think if we see our clinical practice, then there is not a single day when, these drugs are not written. There are so many tricky situations. I was asking Dr. Neeti, that what is the panel going to be? And she said that no. For you all, it's not tricky situation. I said the moment we think that there is no tricky situation, and then a tricky situation comes in, and then you start, thinking, pondering. So in an OPD, one case will be tricky, and definitely, and even more. So I think I'm looking forward to hearing a very, very great, 2 hours of very consolidated learning. So thank you very much.
Thank you, Dr. Shweta and Dr. Indu, ma'am, we would like you to stay on, please. And we would like to hear from you, your comments also while we go through our academic program. So please stay on.
Yeah, sure. I'm logged in.
Okay, thank you so much, ma'am. Okay, Bhavani, over to you.
So now to begin our first session, I would like to invite Dr. Geeta Khanna, who is Scientific Director, ART Unit, Ajanta Hospital and IVF Center, Lucknow. Welcome, ma'am. The second chairperson for this session is Dr. Neeti Tiwari, Senior Consultant, Center of IVF and Human Reproduction, Sir Gangaram Hospital. And the third chairperson is Dr. Piki Saxena, Director Professor, Department of Obs and Gynae, Lady Hardinge Medical College. I would now request our chairperson to introduce the first speaker.
First of all, we should formally welcome Dr. Geeta Khanna, ma'am. She's a very senior IVF specialist from UP East chapter, and we are so obliged to her for taking out time to be with us in this webinar, ma'am. Thank you so much for being here.
Thank you, Neeti. Thank you so much for inviting me.
Thank you so much.
Pleasure to have you, ma'am, with us and be there as an expert for all of us.
Yeah, I feel honored to be invited here. So,
Bhavani, you can share the CV of the first speaker. First speaker, Bhavani.
yeah. So, first speaker is Dr. Rashmi Sharma. She will be talking on re-emergence of letrozole, and she is my friend, first of all, let me tell you. And she is an MBBS and DNB, MNSA, FICOG, Diploma IVF in Reproductive Medicine, Kiel's University, Germany, web editor IFS, then former HOD IVF department, Moulton Hospital, Delhi, and Max Hospital, Pitampura, recipient of CS Dawn Award for Best Paper Presentation on her work on IVF and ICSI with genital tuberculosis at All India Congress of Obstetrics and Gynecology 2010. Then recipient of Hall of Fame Best IVF Specialist in India North at Economics Time, National Fertility Award in 2019, 2023, so many things, 2024. Origin IVF received Best IVF Center in the North India and Most Integrated IVF Team in IVF, Integrated Team in IVF, and India at Economics Time, National Fertility Awards 2019 and 2024, recipient of Best IFS Executive at Fertivision 2018, Kochi, authored various chapters in infertility books of repute, and many national and international papers and paper presentations and publications. So welcome, Rashmi. Let us start. Okay.
And she's from BHU, ma'am, from your chapter only, actually UP East.
Yes,
That's good.
yes, BHU is very close to my heart.
Yeah.
Thank you so much, ma'am. Thank you so much for your such kind words. And I really cherish this friendship. And thank you, Dr. Neeti, for giving me this wonderful, wonderful opportunity to revisit letrozole myself. It has been a great learning experience. Thank you so much. So let me share my screen. Is it shared?
Yeah.
It is shared, but we are seeing all the windows.
Yeah. Can you see
Now
the
we can-
PPT now?
Yeah. Now we can see, just you have to make it full screen. Yeah.
Slideshow.
एंड मोमेंट पे ये पीपीटी अटक गया है शायद. Oh God. I think ये हैंग हो गया है शायद.
Do you want to close it and start sharing again?
Yeah. That's what I'm trying. Yeah. So is it visible now?
Yeah.
Yes.
Okay.
Yes.
So I have been given this topic of re-emergence of letrozole. So, but before re-emergence, we have to understand that how it emerged. So the story of letrozole starts in 2001. So I should say clomiphene was really the queen of ovulation induction since 1956. So for almost 50 years, clomiphene ruled the world of oral ovulation induction, and it was only after a gap of almost 50 years that a new drug emerged, and that was letrozole at the turn of the millennium, which was in 2001, with this pilot study published by Mitwali and Casper in 2001. So this was a pilot study in about 22 patients, 12 of whom were PCOS patients and 10 were ovulatory infertility. And for the first time in the world, they showed that aromatase inhibitor was good enough for ovulation. So in 12 patients with anovulatory PCOS, they could document that with letrozole 2.5 mg once a day, there was 75% ovulation rate and almost 25% pregnancy rate. In ovulatory infertility also, letrozole was doing good. So this was the first pilot study. And one more positive thing that they showed was that endometrial thickness, which we were so worried about all the time in the clomiphene cycle, was doing actually much better in letrozole cycle. There was a significant difference in the endometrial thickness. So the conclusion of the concept study, the first concept study of 2001, I should say it was bang on, and they showed that oral administration of aromatase inhibitor letrozole is effective. Number one, for ovulation induction, not only in PCOS but otherwise also. And letrozole appears to avoid the unfavorable effects of endometrium frequently seen with anti-estrogen use for ovulation induction. So this first conclusion from the very first study still holds true. And the mechanism of action was very simple. We all know it is an aromatase inhibitor. Aromatase is an enzyme which converts androgen to estrogen. So if you somehow make the body estrogen deficient by competitively blocking this enzyme, the body will perceive that the estrogen is not coming, and that's how FSH and LH are released from the pituitary. Then how come from 2001 we are talking about re-emergence? So there was a very big downfall of letrozole, and this downfall actually came with this paper. This was presented as an oral presentation. It was a very small abstract presented in ASRM in 2005 by Bizlan. Right? It was a very small number of patients, about outcome of about 150 babies, which conceived with letrozole, and compared with almost 36,000 normally conceived pregnancies. It never published as a paper or as a full study. It was just a oral presentation and only an abstract published in 2005. And this presenter suggested that the use of letrozole is associated with a higher risk of congenital cardiac malformation. And of course, nobody wants to have a thalidomide like situation. So, in 2003 itself, 2001, the first study of letrozole came. Somehow, Indians were ahead of time. In 2003 only, this paper published in British Medical Journal, and doctors in India prescribe unapproved fertility drug. They were concerned, and this concern already published in 2003, even before that 2005 paper. So bad news always travels fast. Based on just very small study, Novartis in 17 November 2005 actually said that letrozole was not safe for use in pregnant women who were either desiring pregnancy or pregnant. So this declaration was given from the innovator brand, and hence the physicians stopped using it for infertile women. And investigators, they all canceled the research programs related to letrozole and infertility altogether, just based on a very, very small abstract presentation at ASRM. In India also in 2011, government banned the use of this drug, letrozole, which was being used as an anti-cancer drug also for breast cancer for treatment of infertility. So I remember our times in 2011, 12, 13, that if ever we had to write letrozole, we never used to write it on our prescription paper. We used to write it in a very small chittiya, because the papers had started coming that letrozole was not so bad as it was shown to be. So how it re-emerged, the story unfolds. The story came just a year after. So in 2006, Ulandi published a very big study of about 911 newborns. That's almost 1,000 babies. And it was shown that the congenital malformation rate is not higher in letrozole. Right? They compared CC with letrozole, and definitely it was proven that the letrozole does not lead to increase in the cardiac malformations or any sort of malformations to say. Right? So it was came just one year later than 2005. Still in 2011, the drug was banned in India, and there was so much of concern about its use. Then again in 2017, a very big Japanese data, which was taking about 8,522 pregnancies with letrozole published, and it was compared to almost 78,000 women who had conceived naturally. And the outcome was that in the pregnancy outcome, miscarriage rate were in fact lower in the letrozole group, and there was no difference in the other pregnancy outcomes. Okay, so our concerns regarding the congenital malformations of letrozole was absolutely unfounded. From India also in 2014, from Dr. Chakravarti Center, this paper published, and this was the first study of such kind in the Asian subcontinent, right? And they gave a huge number of data of about 646 women and confirmed that it does not increase congenital malformation rate. In the natural conception group, this study found the malformation rate was 2.9%, while in letrozole it was just 2.5%, almost equal to natural conception. In CC group, it was 3.9%. So the concerns regarding letrozole were unfounded. This was the list of anomalies that were found in our Kolkata study. Key messages from this study was that congenital malformation found to be comparable between natural conception, letrozole, and CC, and undue fear against letrozole may be uncalled for. This paper published in 2014. So I will not go into too much detail, but there are hundreds of other studies which have published regarding the safety of letrozole. This is a whole list of those studies, and all of these studies tell us that according to current evidence, letrozole does not increase the risk of congenital anomalies in newborns. This meta-analysis published in 2017 in British Medical Journal. And then Government of India also woke up. In 2017, the ban from letrozole was lifted up. And so we were now free to write letrozole as and how we wanted to. So, okay, now we have ensured safety. What about the efficacy? So, yes, there are thousands of studies now. In 2014, this was a very good study which showed that letrozole was actually better in terms of live birth rates. In cases of PCOD, pregnancy rates increased, and live birth rates increased. They were much better than clomiphene, right? So this was a huge difference of about 44% between clomiphene and letrozole. There was a 44% increase in the live birth rate if you use letrozole in comparison to clomiphene. This published in 2014. This was the conclusion. There were other studies from Dr. Chakravarti's center in Kolkata. They also published in 2012, as early as 2012. And this study said that yes, letrozole has beneficial effects on endometrium, and thereby it potentially increases pregnancy rate after successful OI in women with PCOS. So data was coming from India as well. This was a data from AIMS in 2012. This was also a randomized control trial between letrozole and clomiphene in PCOD, and they also said that letrozole was safe and better, in fact, better alternative to CC in cases of PCOS, and it may be considered as first-line treatment for ovulation induction. So the AIMS study in 2012 itself, said that maybe we are by not using letrozole, we are somewhere missing the point. But imagine in 2011, the India had already banned this drug. Until 2017, it was not open to use. Now coming to meta-analysis, in 2012, there was a meta-analysis which said there was not much difference between letrozole and clomiphene. There was one Cochrane which actually said that clomiphene was better, but this meta-analysis in 2015 very confirmatively said that letrozole is definitely favored. Whether you take primary outcome as live birth rate or pregnancy rate, letrozole was definitely better. In CC resistant PCOS also, I will not bore you with too much of studies, but all the studies were favoring letrozole at one point of time. And then our guideline making groups also started wakening up. And in 2016, first time ACOG came up that letrozole maybe should be considered as first line therapy. And then the other societies followed. In 2018, ASHRAE said that yes, letrozole should be the first line of treatment, especially in cases of PCOS. ACOG in 2018 also said letrozole is the first choice, and ASHRAE in 2023, as latest as last year, has been very clear that letrozole should be the first line pharmacological treatment for ovulation induction for infertile and ovulatory women with PCOS with no other infertility factors. So just to summarize the advantages of letrozole over clomiphene, basically letrozole does not have any negative side effects on thin endometrium. This is one thing. Second thing is that the multiple pregnancy rates are lower in letrozole because it leads to monofollicular response mostly, and it is supposed to have more live birth rates. It is definitely more efficacious than clomiphene, especially in cases of PCOD. Yeah, so that's all. Thank you. Sometimes you just have to die a little inside in order to be reborn and rise again as a stronger and wiser version of you. That's what letrozole showed us. Thank you.
Thank you so much, Rashmi. It was so nice. And you actually showed how it actually re-emerged and come out as a first line of treatment now for ovulation induction and PCOS.
Yes.
So very
Thank
nicely
you so
said.
much, Dr. Rashmi. Very, very nice, the kind of talk which I wanted on this topic, exactly what I wanted, re-emergence of letrozole. One question which I want to ask is, when we talk about, endometrium, right? And we think that letrozole would lead to a better endometrium. Have you always found in your practice that letrozole leads to a better endometrium?
No, ma'am. Dr. Niti, because it is leading to estrogen deficiency in the body. So particularly if you are using 5 mg of letrozole, the estrogen in the initial part may be so deficient that the initial part of the cycle, the endometrium is actually thin. When that effect wanes off, then the endometrium gains prominence. We have to understand that estrogen is leading to endometrial thickness, and letrozole is leading to estrogen deficiency. So if you use a small dose 2.5 mg, the lining may be really good, but if you use high dose 5 mg, then in the initial part it may be thinner. And this is what I have seen in my practice also.
Yeah, So the benefit which it talks about on the endometrium is often not seen. Yeah.
Yes.
But whether it, further leads to any effect on the conception rate, it doesn't look like that, right?
No, no. In PCOD, very clear that live birth rates are much higher with letrozole.
Yeah. Thank you so much. Thank you.
Thank you. Thank you.
Dr. Rashmi, and we would like you to stay for panel discussion also
Yes.
later on, and yeah, we would like to have your comments there also if you're there.
I would be there. Yes.
Okay, thank you.
Dr.
Dr.
Nehru is asking which is better, 2.5 or 5.
Dr. Rashmi, excellent talk. I must congratulate you for an excellent talk. And
Thank you.
we must all also understand that the DCGI has approved letrose only for 2.5 milligrams.
Yes, true, ma'am.
Although we have seen robust evidences from different literatures and different studies, 5 to 7.5 can be used, but it is not approved in India. And Dr. Rashmi, another thing I am seeing is that although we all say that it is unifollicular, monofollicular, but many times it does have a multifollicular development.
Yes,
Also.
it does have multifollicular, especially with 5 mg.
Yeah, especially. So very nice talk. Thank you so much.
Thank you, ma'am. Thank you.
So, anybody else will like to, welcome Ruma, or I should go ahead?
Ma'am, please go ahead.
Acha. So now we welcome a second speaker, Dr. Ruma Satvik, and her topic is clomiphene still relevant in PCOS? So Dr. Ruma, she's a DGO, DNB, FNB, reproductive medicine designation. She's a consultant center of IVF and human reproduction, Sir Gangaram Hospital, New Delhi. Special interests are low cost physiological stimulation of IVF and unexplained infertility, then teaching faculty and guide, teaching and reviewer, Journal of Human Reproduction Science, Reproductive Science, then publication, 6 papers in PubMed indexed journals and 5 in non-indexed journals. So welcome, Dr. Ruma, and we are here to listen to you.
And one thing I want to add here that Ruma is a very good orator, and clomiphene is very close to her heart. So she is very fond of clomiphene and has a lot of work done on clomiphene also.
Right. Also, I'd like to state that that's an old CV from 6 years ago. Things have been updated. I gave it to Bhavani to use the new CV. I don't know if she got it, but yeah, thank you. I thank you, Dr. Geeta, for introducing me. And I know that letrozole scores above clomiphene citrate in PCOS. My job is just to take a closer look at why we continue to use it even today, and if we do, what you can still do right with it. So remember, the buzzword here is PCOS, since the webinar is on PCOS, and that's the only population we'll be concentrating on. And briefly, if I had to put it as to why clomiphene citrate is still around, so that would be, I can divide it into both the indications, PCOS and others. But in PCOS, and I'm going to be arguing this rationally, hopefully Dr. Rashmi will be around to listen to this, that the absolute difference of live birth in randomized control studies is not radically high with letrozole than as compared to clomiphene citrate. We know that it is high. We'll look at closely look at what the evidence is. Of course, it's lower cost, it's easily available, and I can say for myself, old habits die hard. So might as well learn its correct use. For others, unexplained, of course, it seems to fare better than letrozole, largely because it tends to produce more follicles than letrozole would in a single use. Also, and that is what you're looking for in an unexplained infertility woman, but also that clomiphene citrate has been used for simultaneous ovarian stimulation and LH suppression. And this is where I use it commonly, and that's where the reference to why I'm fond of clomiphene citrate. I use it for both these indications together, ovarian stimulation and LH suppression, originally known as the CATO protocol. So let's just look at the first point. And these are the summary of findings of Cochrane 2022, which compares clomiphene citrate with letrozole. So you can see that the first column here is looking at SERMs, and I'm taking it to mean clomiphene citrate. The second column here is looking at letrozole, and these are the number of participants. So the first outcome is live birth rate. And this evidence comes from 11 RCTs 2060, which is fairly strong evidence as reflected here with these 4 pluses. And it's saying that it's 307 per 1,000 live births versus 204 per 1,000. And if you look at the OHSS rate, which is also coming from a very sound place of 1848, this, they say there is not too much difference between 7 per 1,000 to 5 per 1,000. If you ask me, it would be 0.07 versus 0.05. That makes it 0.02. That's the difference in terms of rates. So a risk difference clearly is none when you talk about OHSs. And so let's quickly look at what does a live birth rate difference of 204 per 1,000 versus 307 per 1,000 mean? So we're looking at clinical meaningfulness of this. So remember that all these 11 RCTs are looking at cumulative live birth, not per cycle live birth, that all of them have enrolled women to receive up to 6 cycles of treatment. So whatever results are from those many cycles, right? So when you say how many numbers do you need to treat in order to get one pregnancy, which is basically absolute risk difference. So 204, 307 per 1,000 is actually a difference of 100 per 1,000 or 10%, 10 per 100. So that translates into when you try to calculate NNT, it translates to 10 additional patients need treatment over 3 to 6 months to get one live birth, which is fairly good, if you ask me. But if you were to translate it into cycles, it means 32 cycles after letrozole versus 32 cycles after clomiphene citrate, you might get one additional live birth, right? So that is something we have to keep in mind while counseling patients. What else are we saying? So those 11 RCTs, if you look at, I'm just going to minimize this because I can't see. I hope you can read this, but even if you can't, you can come to these lines here, which represent the actual effect size and the confidence intervals. So out of these 8 studies, which they have used to determine the difference in live births between aromatase inhibitors and clomiphene citrate, you can see that not all of them are saying that there will be an increase in live birth, but yes, there are at least 2 studies and one by Ligro, which of course Dr. Rashmi also showed us, and it has a very weighted square, which means that it's a large study, 374 patients per arm, 374, 376, which is saying with a very low risk of bias, all the 7 circles are in green, which means that the bias risk is low. So this is clearly tilting the effect to one side. And I would definitely believe what Ligro is saying if the risk of bias is low. Right. So now let us look at Ligro's study. And this is something we also saw in Dr. Rashmi's talk. And it's the same one I'm bringing here. But I'm urging you to look at something else, which I would look at closely, because to me, this is a very interesting graphic. So the first one here is talking about live births, and days from, so these are known as Kaplan-Meier curves, right? So as you move in time, what are the live birth rates? The percentage is what these 2 lines depict. And clearly, there's a huge difference between letrozole and clomiphene citrate. In terms of absolute risk difference, remember there's always a difference between absolute risk reduction and relative risk reduction. So this is here is, let's say if it was 20% or 19%, as the study suggested, about 10% more, and it comes to around 29% with letrozole. That is what it means. So in term, if 3 to 6 cycles of clomiphene was yielding a total live birth rate of 19%, then letrozole would yield a total live birth rate of 27 to 28%. But here you see that they are pretty much the same till 350 days after randomization. What does this mean? 350 days is roughly 1 year. That the real difference begins to emerge after 1 year, right? So here, what I'm trying to say, to me, it sounds like the first 3 months of use of clomiphene and letrozole resulted in no change in live births. It is only after continuous use beyond 4 months is when the live birth differences start to emerge. And so on, for they have done a sub-analysis for BMI less than 30.4. The magic figure, again, is somewhere between 350 and 400. This is where the digression happens. You look at BMI more than 30.3 to 39. Again, this is where the digression happens at 350. And once again, so to me, it seems like the first 2 or 3 months of use of either drugs is similar as per this in terms of live birth rates as per this graphic. Now, I don't want you to go into this. I'll quickly move to the next question. So what really is happening? What is happening here? Why are the live birth rates lower after a third month of use? And the answer lies in pharmacokinetics. This is what I'd like you to pay attention to. This is something we read through our postgraduate years, but never pay much attention to. So now you do know, I'm just going to quickly go through this. 2 isomers make CC, cis or ZU 62%, trans or N 38%. The cis, you have to try and remember, is the anti-estrogenic isomer, which is like totally blocking or doing a complete blockade of estrogen receptor. And it's because of cis that you have your ovulation, the properties that ovulation-inducing properties come from the cis isomer. Trans, on the other hand, is partially estrogenic, which means that it is not doing a complete blockade at estrogenic receptors. The other difference is that cis has a half-life of less than 24, the one that is actually acting, and the one that doesn't really act, at least the way you want it to, has a half-life of 7 days, right? What does this mean? Trans has been detected for up to 30 days in serum through radioactive tracer studies and all that. So it can accumulate. It's the trans that can accumulate over 2 or 3 months of use. What happens if a partially estrogenic isomer tends to accumulate consecutively, sort of over consecutive use? So this is again just to show you what is happening to ovulation rates. This is through another study. This is in the first month, ovulation has happened here. This is giving you the probability of ovulation. In the second month, by day 52, it has reached here. By month 3, 4, you can see how it flattens out beyond this if you are using it consecutively. So the trans or N isomer builds up in the serum. Its partial estrogenic activity negates effects of cis isomer on the pituitary. Therefore, ovulation rates decline after 2 or 3 consecutive months of use. Best to give it a break after 3 months of consecutive use. That is what should be one of the take-home messages that I'm trying to give. There are 2 more. One is thin endometrium, and there are an often kind of quoted problem of cysts that can develop with clomiphene citrate. Answers are again ingrained in its pharmacokinetics when we talk about thin endometrium, and Dr. Rashmi has also effectively answered this question, that initially you will see thin endometrium. You have to give some time for its clearance. And the receptor blockade, often the one that is caused by the absolute anti-activity, is likely to be cleared by day 5 of the last dose, so that by the time you reach the day of ovulation, the endometrium would have bounced back, right? So it may still be lower than what is seen in letrozole. I'm not arguing with that, but it may not be as thin as you suppose it would be, like 5 mm or 6 mm, if you were checking it within 3 days of stopping or giving the last dose. But if you were to check, so ovulation usually happens 7 days after the last dose, 6 to 7 days after the last dose. Now, this is also a very interesting graphic to me. I'm just going to end after this. And this graphic is talking about what the optimal follicular sizes are at ovulation with clomiphene citrate and pregnancy probability by endometrial thickness. So in the 4 columns that you see, the 4 panels. The first one belongs to women who had endometrial lining of less than equal to 7 mm. The second one has lining of 8 to 9, 10 to 11, and so on, till more than equal to 12 mm. You can see that each one of them, the maximum probability of pregnancy is achieved with an optimal follicular size of 23 to 20, slightly again 23 to 24, and this is in fact higher with that, somewhere 25 to 26. This is where the peak is reached at 27 to 28. Now that we don't really wait that long, but it is usually helpful to not trigger women who have received clomiphene citrate at sizes 18 to 20. You allow it to mature more, and then maybe even if trigger, of course, there are enough, and I won't be talking about it today, there are enough evidence in literature through various studies which suggest that trigger is not really needed in clomiphene citrate-induced cycles, right? So you just allow her that, or you monitor her through Elliott strip if you're trying to time an IUI. So we have discussed thin endometrium, but what happens if it persists with CC? Literature has said that you can use lower doses of clomiphene, and as low as 25 milligrams for 5 days has been given, but also 50 milligrams for 3 days has been given. You could, of course, do all the rest. You could switch to a gonadotropin, letrozole, and all those cycles, rule out other causes of thin endometrium. So cysts is a problem which is particular to poor responders. You'd rarely see cysts with polycystic ovarian syndrome, but cysts you'll see in women who are regularly ovulating, have short cycles, advanced stage, poor ovarian women, poor ovarian reserve women. Also, when more than higher doses, more than what is needed, has been used to induce ovulation. It can also happen in late start cycles when you're starting from day 5 instead of day 2. So this is the cost. Not that it matters to anyone. 87 versus 313 is not really a huge difference, but here 87 is for a strip of 10, 313 is a strip of 2.5, just to keep that in the back of your mind. It's not a huge difference. But so that's my end, the last slide. Why is it still around? Maybe because it's still available. It's still cheaper than letrozole. The absolute difference of live birth exists, no doubt. I'm not going to argue that. And it comes from very strong place, the evidence. But you have to know what the absolute difference is, and it's coming after 6 months of use. That is something you have to keep in mind. A better understanding of its pharmacokinetics should help in improved outcomes, and that is where I'll end. Thank you.
Excellent talk, Ruma. Excellent. But I want to know from your practice now, which are the group of patient? Are you still using it in some patient as a first line, or which are the group in which you
PCOS, I still prefer letrozole, not clomiphene citrate. But I use clomiphene citrate in women with unexplained infertility to induce 2 or more follicular development. And sometimes I feel that clomiphene citrate is not enough. Then I do add a little bit of gonadotropins simultaneously. So maybe on alternate days, because you don't want too many follicles. So day 2 to day 5, perhaps 50 milligrams for women with a weight of less than maybe 60. 100 milligrams for women who have more than 60 kgs of weight. I might want to add UMOG based on their reserve. This is HMG. I'm not going to name any brands, but HMG I do add in women with unexplained infertility, especially those with poor reserve. I'll add it simultaneously. So closer to the start of clomiphene citrate. Day 2 to day 6 is clomiphene. Day 3, day 5, day 7 might be HMG.
Yeah. So in PCOS, it has taken a backseat, right?
Yes, yes. I would agree with that.
And have you tried it in letrozole resistant cases where the cost is a concern maybe?
Yeah, because I mean, 313 is not really
No.
a
I'm saying if a patient is resistant to letrozole,
resistant.
instead of shifting to gonadotropin,
Hmm.
have you tried clomiphene instead?
So, I mean, off and on, and I wouldn't be able to give you data on how it works. The one problem that I've faced with letrozole is that if I start it, and with the anovulatory women, you needn't start it on day 2. You could start it on day 5 or day 6 also. That's the other thing. So if I start it later in the cycle, letrozole is likely to induce a bleeding, because what it'll do is whatever estrogen is there, it's going to cause a drop in that estrogen levels because of its mechanism of action, right? Aromatase inhibition. So whatever that little estrogen was there, if it drops further, that induces some bleeding a little bit. And women, but of course, you can always reassure them that this wouldn't matter. And you come back to me with a follicle monitoring 5 days after stopping the last dose of letrozole. So yeah, but so that doesn't happen with clomiphene citrate, for instance. That mid-cycle bleeding doesn't happen with. Yeah.
Thank you. Thank you.
Can I ask you, Ruma, one question? If I have the permission from the chairperson.
Yes, please.
Ruma, I just want to have your opinion regarding clomiphene plus letrozole together. Have you ever used?
I haven't. If I have to combine drugs, I'd do it with gonadotropins. I haven't really, because both of them are anti-estrogenic, and that is my reservation against using both of them together. I'm not sure how long would the blockade take to reverse when we are talking about, let's say in IUI, because you do want an optimal endometrium.
What I've seen actually, Ruma, when I've gone through the studies, and even I have given this a project, the results were good, surprisingly. Only 2.5 litros, and clomiphene was 50 milligram in that.
All right.
So you start from day 2 together.
I'm aware of. Yeah, I'm aware of one.
We also tried, Dr. Renu, because we read these studies, combining drugs together, and especially in our general OPD free patients, sometimes cost is a concern.
Yeah.
We tried, giving these two together, but never found very encouraging results. So we kind of gave up, never gave it as a study. But we would love to know what you, finally find in your study. Which
Definitely, I'll project it later on.
Right.
Sometime.
Right.
Thank you, Dr. Ruma.
Thank you.
So thank you, Dr. Ruma. You cleared so many.
Dr. Ruma, one more thing I wanted to ask. Have you ever given extended or increasing doses of letrozole beyond 5 days?
Yeah, so as long as I'm within the safe limit, which is 700 mg and under, 750 and under, I have.
7.5. You have increased the dose from 2.5
You're
to
talking
5
about
in the same
clomiphene
cycle?
citrate, right?
Sorry, we are in the clomiphene. Yeah.
Are you talking about clomiphene citrate?
Yes. I'm
So
talking.
clomiphene, total dose, recommended dose for 1 monthly use is 750 milligrams. So if I am under that limit, so yes, I can give it from 5 days to maybe 7 days if I'm using 100 mg. If I'm using 50 mg, I can probably go up to 12 days if that's needed. But I don't prefer that. I like to see what, so after 5 days of use, I like to see maybe by day 12. So let's say I've given it between day 3 and day 7. Then 5 days later is the first I'll call her for a monitoring, which is day 12. Day 12, if there has been some change in cohort size, baseline was, let's say, 5.55666, but by day 12, and use the same principles as we do in IVF, by day 12, there's still no dominance, but the overall cohort has moved from 5 to maybe 9 or 10. I would want to take my chances and wait. And wait as in maybe repeat this 4 days later or 5 days later. And if the cohort, at least one of them is moving forward, we know we are successful. But if none is moving forward and everyone are stuck there, I might want to now add gonadotropins at this point, even if it is day 15 or day 16 of cycle.
Okay.
Yes, Dr. Rashmi.
It was such a nice presentation, Dr. Ruma. Actually, I was wondering that what are you going to say in favor of clomiphene, in spite of such huge evidences in favor of letrozole. But this was such an interesting observation from the Legros study, the time to randomization, so that means in the initial part, to the 3 to 6 months, actually there's no difference in live birth rate between letrozole and clomiphene.
Yeah.
So that is such an important thing that you have pointed out. So maybe in the initial cycles, I don't know whether we should be depending on letrozole so much.
No, as in, I do like to give a break after 2 consecutive clomiphene citrates. I don't continue like one cycle after the other. And you know my reason, I've presented it here. So, however, I mean, I really would ask you to not stick to any one drug. There are pluses and minuses to both. If,
Yes.
like, let's say 2 or 3 cycles of clomiphene citrate have not worked, even though it has caused ovulation, I would want to move on to the next step. If that means moving to letrozole. So, and it's just that all I have to say is we still have 2 drugs, oral drugs on the armamentarium. And we just need to know how to judiciously use both of these. Yeah.
Yes.
As Dr. Neeti said, if letrose is patient is not responding on letrose, I sometimes shift to clomiphene before going to gonadotropin
Right.
in
Okay.
PCOS.
Right.
Thank you, Dr. Ruma. It was very nice.
Thank
And
you.
I think we can go for another talk now.
Yes.
And the next speaker is Dr. Renu Tanwar, and her topic is walking the tightrope gonadotropins in PCOS. So welcome, Dr. Renu, and she is a visiting fellow at Mercy Hospital, Melbourne, Australia, visiting fellow at Somerville's University, Budapest, Hungary, okay, and visiting fellow at University Hospital, Brazil. Then has organized CME and conferences in IVF and reproductive techniques as an organizing secretary. Joint Organizing Secretary, AOGD 2022 and 2023, Treasurer of AOGD 2016 and 2017. Then
Thank you so much,
Executive
ma'am.
Member of IFS, accredited with many presentations, faculty lectures, publication, and chapters in various books. So welcome, Dr. Tanwar.
Thank you so much, Geeta, ma'am. Thank you so much. Can I share this thing? Is my screen visible?
Yes, Dr. Renu.
Thank you. Thank you. Should I do full screen or is it okay?
No, make it full screen.
Yeah, that will be better.
Yeah, some people could be on the phones, na? They're
Okay. So thank you so much for the introduction, and definitely the 2 lectures were so good. And I know gonadotropins in PCO, we are really very jittery at times in using these drugs, and it is definitely a tightrope when we walk on. So we all know that gonadotropins are indicated to treat infertility caused by anovulation PCO after failure of oral medications to induce ovulation, that we all know, and we all are using that. Most common second-line treatment in PCOS, that is what Cochrane and all the guidelines do say. Now it has become a second-line treatment in PCO women. And obviously, women who do not conceive within 6 ovulatory clomiphene citrate cycles can switch to gonadotropins. Now, gonadotropins, we all know, is associated with increased risk of OHS and multiple gestation pregnancies, and hence a low dose gonadotropin regimens are strongly advised. We also know that anovulatory cycles are in 20 to 30% cases of female infertility, and are always the aim is of monofollicular development. Now, I think all PG should understand this. This cycle is very important regarding how does everything work, when you know the mechanism, then things will be better. So this is where you will know that the FSH works on the granular cells, and this is how the aromatase production takes place. And here is the LH, which also stimulates the androstenedione production by the theca cells that diffuse into the granular cells, and aromate converts the estradiol into the estrogen. This two-cell gonadotropin, everybody should be knowing that. Now, regarding, we also know why there is a single follicle development in natural cycle. This mechanism should be known by everybody. Whenever there is a dominant follicle, it will secrete the estrogen. Now, this will have a negative feedback on the FSH. And when the FSH is dropped because of the negative feedback. The smaller follicles with fewer FSH receptors no longer get stimulated and they don't grow because of the decreasing FSH levels, and they go into atresia. And that is why this mature follicle will keep continuing, and we have a monofollicular development in a natural cycle. Now, why we are all interested in this is ovulation induction is that we want to have maybe another 1 or 2 follicle, which is good for an IUI cycle, and maybe this will increase the pregnancy rate. So this is the picture which shows the recruitment selection, how it is about. Then there should be a FSH threshold where the dominance of the follicle will take place, and then all of them rest of the follicle atresia, and then this is the threshold which is required for the ovulation to occur. And we also should know about the LH therapeutic window. And we all know that PCO women do have LH levels at high rise. And that is why there's a ceiling, there is a threshold level of LH, and there is a ceiling effect of LH. LH somewhere between 1 and 5 would be better, because anything which is more than 1.2, if it is there, because this level is good, at 1.2 to 5, because this is for the optimal follicular development, and levels should be above the threshold but below the ceiling effect. Where there is high LH levels, we know there's a lot of follicular atresia. There's non-dominant follicles. That is why PCO at times really take longer time to have a dominant follicle. Oocyte development is compromised. The suppression of granular cell proliferation is also there, and premature luteinization is also seen. Whereas if the levels are too low, we also know that impairs follicular growth, impairs oocyte maturation, and inadequate androgen and estrogen synthesis. Now, type of ovarian stimulations, we know there are different types. There's a substitution therapy for the WHO type 1, that is hypogonadotrophic hypogonadism. We all will be talking about the ovulation induction, which is used in cases of anovulatory or dysovulatory cycles, that is WHO type 3. Now, physiology, what do we want in an ovulation induction? We want a monofollicular growth in anovulatory cycles. Maybe if we want a more super ovulation, maybe 1 to 2, 3 cycle, 1 or 2 follicles more we require, whereas in IVF and ICSI, we definitely want multifollicular. Now, regarding this, the gonadotropins, which are used to induce ovulation, we know there are different indications, and please see the middle one, that is anovulatory, PCO resistant, or unresponsive to metformin and clomiphene citrate. This is where we are usually using the gonadotropins. Now, when you have also known that the pregnancy and live birth rates were achieved faster with low dose FSH than with clomiphene citrate, but definitely the cost factor is there. Definitely the clomiphene citrate is convenient and less costly when we talk about gonadotropins. Now, the principle, what is that in this ovulation induction, we know that it is based on the fact that initiation maintenance of follicular growth is brought about by a transient increase in the duration of FSH level above the threshold level to recruit a limited number of developing follicles. Just see here, that is what the FSH, we need 2 or 3 follicles, and that is why we just need that much rather than having a high this thing, so that we don't have a multifollicular growth. Now, this is regarding the difference between the gonadotropins, the urinary and recombinant. We all know about this is extracted from the urine. It is contaminated with urinary proteins. It can be given intramuscular or subcutaneous delivery, whereas in cases, and these are the different names which are available, the human menopausal gonadotropin, the urinary FSH, the highly purified urinary FSH, and then we have the recombinant, which is of the DNA technology, recombinant DNA technology. It is produced in limitless quantities, free of urinary proteins. That is why more and more people are definitely going towards the recombinant therapy. But definitely in IUI, we are still using the urinary at times, depending upon the pocket of the patient. And definitely this is better because of the batch to batch consistency, and definitely it has a subcutaneous delivery system, and it is quantified by the protein content. Definitely the price is definitely very high. So that is one of the factors where recombinant maybe people don't use at least when that is in comparison to the urinary gonadotropins. Now, this is, we know how the gonadotropins has come up. It was in intramuscular administration, then continuous, then came about the subcutaneous, and then obviously we have the injectable pen. So just see the transition of this. Now it has become more safe, the quality are more good, consistency is definitely better, and it is also patient convenience is now there. Now, when you compare the different urinary and the preparations, so this is we have here, we have the HMG preparations, the highly purified HMG. Just see the urinary contents. You should know at times how much is the urinary, the PGs at least should know about all this. The urinary proteins that I just brought it, how much FSH and LH it has, and this is the HMG has 75, 75. The highly purified also has 75, 75. But purified FSH, the unit proteins are less than 5%, but they have more of a FSH and less than 0.1% of LH, and highly purified, that is the difference between all of the FSH and highly purified is the depend upon the LH content which is there, and just see the LH content is so low in cases of highly purified. So that is what at times it is asked in the exam. Now, these are the recombinant varieties which are usually given subcutaneously. And this is the different forms. It can be FSH recombinant could be 75, 150. The pen forms are available in 300 to 450 and 900. And that is how. And even the HCG has a recombinant that is Ovitril, which is given in subcutaneous form. We do have a recombinant LH in the name of Luveris. Now, we also know that regarding the recombinant FSH and versus urinary FSH for ovulation induction subfertility associated with PCO, the Cochrane 2007, even the latest says there's no significant difference in ovulation, pregnancy, miscarriage rate, multiple pregnancy rate, and OHS. No sufficient data to determine whether recombinant FSH or urinary FSH is preferred for ovulation induction in women with PCOS. Ovulation induction with urinary versus HMG for clomiphene-resistant PCO, they said there is no significant differences in pregnancy rate. However, given similar cost, potential advantages in terms of purity and possible reduction in OHS, highly purified FSH is likely to be widely adopted in future. And there is insufficient evidence of a difference between HMG and recombinant FSH on ongoing pregnancy rate and live birth. And hence, whether you are using recombinant FSH or urinary, the results, all the reviews say that it doesn't make much of a difference. Now, which gonadotropin to be used? I said if the pen or multi-dose vials are ideal in PCO, as you have the option for small increase in that. So that is very important. When we have to use only minimal dose, I think so that is how it has to be done, rather than just jumping on higher doses and then landing up in OHS. That is very important. And exogenous FSH alone can induce ovulation in women with PCOS, because definitely the endogenous LH levels are adequate in these patients. So at times we don't need to use any LH in between. And there is no significant advantage using any specific gonadotropin preparation. I just told you in the previous slide, even the fertility study 2020, this is the committee opinion. This also says there's no difference in the gonadotropin preparations which we are using. And the meta-analysis also concluded that the outcome of treatment achieved with HMG and with FSH alone was similar. So that is very clear. All the committee opinion, this is what they are all coming. So there is no confusion in this. Now, various types of gonadotropin have been developed, and I just told you the previous one, and this is highly purified. That is the recombinant variety has just come up. So regarding the ovulation, which type of protocol we have to use? There are different protocols. There is step up, step down, and then we have the conventional and low dose. One by one, I will just tell you. So this is a conventional regimen where you are using the FSH-LH and 150 from day 2. For 7 days, and then you monitor the patient on the day 7, and again you decide whether there is no dominant follicle, all the follicles are less than 10 mm. You again increase by 75 international unit, and then you wait when the follicle is 18 mm, or the E2 is something around 100, 1000 to 1500, and then you can give an HCG. So that is the conventional regime. Low dose step up protocol is less complicated. You start with a lesser dose of 37.5 to 75 international units, selected dose of gonadotropin given for a week, and then you assess for the follicular growth. If not satisfied, then you increase the dose by 75. Once the growth is seen, you maintain at this dose till you have a mature follicle that is around 18 mm. So chronic low dose step up protocol, I think so this is what most of the people use in cases of PCO, because here you're starting day 2. You do a scan, use lower dose, maybe between 37 to 75. Again, call the patient after 7 days, increase the dose by 50% only. That means you have to just increase by 37.5. So just increase it little by little rather than jumping too much. And again, do a scan on 21. And again, you increase the dose if you see that there's no dominant follicle more than 10 mmNC. That is how you have to. I think this is a much better way. Everything is in your control. And the treatment cycles usually last around 28 to 35 days. But definitely you have to see that you don't land up in having multiple follicles, and all that has to be taken care. So ultrasound follicle monitoring is a must in these cases, and it has to be very careful. You just can't leave them on juniors and think that everything is going on fine. These patients have to be monitored by yourself. Then the step round regime is that you start with 150 for 5 days, and then you decrease the dose to 102.5 for 3 days, and then 75. Actually, this is, I think, so we are very reluctant to use a very high dose in cases of clomiphene, because at times we don't know how the patient will respond. The first cycle is so undecided that you don't know. It's always better to start with a lower dose and then just see how the patient responds, and then you can keep on increasing. So when you compare the step up and step down protocol, the rationale is obviously a monofollicular stimulation. This is beneficial in PCO, where step down protocol stimulates the physiological cycle, and this is much better in cases of CC resistant PCO. But I will definitely tell you that you always go in a stepwise manner. And obviously, these are the advantages and disadvantage of the both of them. This has a reduced FSH ampules, reduced cost of cycle, and avoids multiple pregnancy. But this, though it says that, but then you have to be really careful. Intensive monitoring is required, and in cases of a step protocol. And cycle cancellation rate may also be there if you see multiple follicles or intermediate follicles coming up. 30 to 40% times at times you may land up in cancelling the cycles. So then there are also the sequential regimes, and another one is the conjunctional regime. The sequential regime is that you have given CC or letrozole, but then you start adding in the FSH or the gonadotropins from day 8. So day 3 to day 7, you have given an oral Ovulagen, and then you can add the FSH and then monitor the cycle. Whereas in conjunction, that means you're trying to overlap the gonadotropins. Maybe from day 3 to day 7 you have given, and somewhere from day 6 you tend to add the FSH, and then you keep monitoring the cycles. And when the follicle is ready around 18 mm and ET is good, you can then give an HCG trigger and do an IUI cycle. So regarding the recommended approaches, I was just telling you that the first dose finding cycle is to begin with the low dose of gonadotropin. Just understand this. You always go in a low dose, you will be much safer, and definitely keep on observing the patients. And I think so pen devices, though they are costly, but yes, you can actually tune them. Maybe just you can, how much you want, that can be done with that much better. And in subsequent cycles, treatment generally begins at the threshold of the response previously determined. So obviously, one cycle you have given, always see what happened to that previous cycle. Did she get a follicle with that much dose? Did all that has to be seen? Then only you should think of increasing the dose in the next cycle, or whether you have to take the same dose. So although 7 to 12 total days of treatment is typical, longer duration of treatment may be required in PCOS, and that is the same thing which I was telling. So regarding the monitoring, we always do a day 2 scan. Please do it and just rule out functional cysts. If they are present, that means the stimulation is not going to be good, and that is what that has to be ruled out. And because this is what the patient is paying, so that is very important. Then after 4, again you do a previous scan. Usually after 4 or 5 days of gonadotropins, and this is how we do. Maybe day 2, then we can call them after on the day 7 or day 8. And whether you want to add gonadotropins or whether you started from day 2, it depends. The monitoring will depend upon that. And we all should know that any dominant follicle secretes between 150 to 200. So it's not necessary that every time you have to do an E2. The number of follicles which are developing, you may have a great idea that even this much dominant follicles, so this much is the E2. Usually in our hospital, we don't go for an E2 test. Usually we see the follicles and decide for the trigger. So optimal ovarian stimulation for an IUI, 2 to 3 follicles with diameter 18, I would say 2 would be better. Then estradiol levels, definitely each follicle is secreting. Anything you find that there are more than 15 mm follicles, intermediate follicles, please don't try to trigger the patient. You can avoid, just don't add the trigger and lead the patient to OHS. So definitely the size, what is the size of the follicle? Definitely 18 to 20 mm, and oral ovulations, definitely we go for a 22 kind of thing. But for gonadotropin, 18 to 20 is good enough. Regarding inducing ovulation, yes, HCG can be used in the dose of 5,000 to 10,000, or you can also use recombinant HCG in the dose of 250. So they are all better. After ovulation, within 36 to 48 hours, you can do IUI. Regarding the monitoring of the cycle, I said it has to be very robust. And then at times people do use GnRH agonist as well to trigger the ovulation by stimulating a sudden, at times if you think that you are having, but what I would recommend is that never try to trigger the patient if you think they are around 2 follicles bigger and many intermediate follicles. Please don't. It is better to leave the patient. And PCO patients, because they are very high risk for the OHSS. Now, regarding the, this is a trial regarding the use of antagonist, which has been used at times, but this was a meta-analysis and they came to this conclusion, suggested GnRH antag can reduce the incidence of premature luteinization, but this may be useful in non-PCO patients, but its role in PCO patients is still insufficient. So usually we are not using, but yes, if you want to avoid a Sunday or a Saturday weekend for an IUI, maybe that can be used. But as such, there is no evidence that is used that it may increase the cumulative pregnancy rate in cases of PCO patients. Regarding luteal phase progesterone, definitely there are high E2 levels. That is why there is inadequate progesterone levels in the luteal phase. But definitely, the committee opinion is also opinion there is insufficient data on women with PCOS to become luteal phase with progesterone. Outcome with gonadotropins, we know that the ovulation rate is definitely good, 76 to 95% pregnancy rate per cycle, somewhere between 20 to, I would definitely keep it at 20 to 28%, and cumulative pregnancy rate, maybe after 6 months, around 36 to 32, 62% in PCOS, but definitely complication rates of multiple gestations and OHS and miscarriage rates are high. Regarding this, whereas the systematic review regarding the type of gonadotropin, I told you the pregnancy rate, even this was the latest committee opinion when they said the systematic review of 13 studies evaluated ovulation induction with gonadotropins in alloovulatory women and found the pregnancy rate is around 15% per cycle, 41% per patient over an average of 2 to 3 cycles. So that is why the gonadotropin, definitely the pregnancy rates are higher, and when we compare with the ovulogins, and definitely the type of gonad do not make much difference. So regarding the contraindications, obviously we should know that primary ovarian failure, we are not going to use it. Uncontrolled thyroid and adrenal function should not be used. Undiagnosed abnormal uterine bleeding, gonadotropins are all contraindicated. Even ovarian cyst, if there is there, you should avoid using on day 2, avoid using this. And even if there's a prior hypersensitivity to the particular gonadotropin, these are the recommendations of not using them. So the net result is that the recommended starting dose is 37 to 550 or 50 international units per dose. Small dose increment of 50% of the initial or previous FSH dose is better. The donation of gonadotropins, how many cycles, that is individualized. At times people, I don't say that we should go for around 6 cycles, but definitely 2 or 3 cycles, you can come to some conclusion that if the patient is not getting pregnant, we have to switch over to an IVF. And low dose FSH protocols definitely are effective in achieving ovulation in patients with PCOS. Intense ovarian response monitoring is required to reduce complication and secure efficiency. And definitely a strict cycle cancellation criteria should be agreed upon with patient before therapy is started. You have to counsel the patient that yes, the cycle may get cancelled. This can happen. The complications, everything should be told. And we definitely all want to prevent multiple pregnancies and OHSS. So regarding the comparison of the gonadotropins, the pregnancy rate, I told you this is with the natural cycle, 3.3%, clomiphene plus I 9.5, CC plus HMG and IUI 13%. Definitely, I just told you it is around 18 to 20%, definitely. So this is an algorithm, again saying the same thing, that is the second line management protocol. This is from the International Evidence Guideline for the Assessment and Management of PCO 23 and 23. This also has said that the clomiphene the gonadotropin has come as the second line now. So regarding all this, I have already told you multiple gestation and cancellation rate should be stringent when more than 2 follicles of 15 mm develop. We should be very, and intermediate size follicles, you know, at times they don't tend to see these intermediate size follicles. That is what is missed, and then patients is given a trigger and then things go wrong. These are the STA 23 guidelines regarding the gonadotropins. He said gonadotropin alone could be considered rather than clomiphene citrate in therapy in a woman with PCO with anovulatory and to improve the ovulation, clinical pregnancy and live birth rate. So definitely gonadotropin has a role. Gonadotropin alone can also be used in cases of clomiphene resistant or failure patients, definitely. And gonadotropin should be considered rather than combination of clomiphene citrate in women with PCOS who are anovulatory. So definitely along with this has obviously definitely in cases of clomiphene citrate resistant patients. And regarding either gonadotropin or laparoscopic ovarian surgery could be used in women with PCOS who are anovulatory and fertile, definitely only after counseling on higher live birth rate and higher multiple pregnancy rate with gonadotropin. So you have to judge what you have to do, whether you have to go for a gonadotropin next cycle or laparoscopic ovarian. Definitely consult the patient regarding the multiple pregnancy rates and they definitely laparoscopic ovarian surgery has a very limited role at times that indication should be known and then only the patient should be offered. And this is the second line pharmacological treatment again. And definitely expertise is required for the intervention for gonadotropins. The degree I just mentioned about the same, I'm just repeating because this is the latest 2023 guideline, which also says a low dose step of gonadotropin protocol should be used to optimize the chance of monofollicular and implications of potential multiple pregnancies. So these are nearly the same things which are saying, which I've just told you. And definitely the live birth rate, clinical pregnancy rate per patient, ovulation rate per cycle are higher with gonadotropins than with clomiphene citrate. So this is just a summary which I just told you. And thank you so much for your patient hearing.
Thank you so much, Doctor. You spoke you extensively explained all the efficacy and the safety of gonadotropin and compared all the modalities of ovulation induction. Thank you so much. Any questions in the box?
Dr. Renu, wonderful talk, comprehensively you covered everything starting from all types of protocols and the challenges and how we have to take precautions to prevent OHSS at any cost, especially in PCOS patients.
Thank you so much, Vicky. Thank you, Geeta ma'am. Thank you.
Thank you, Dr. Renu. A very comprehensive talk indeed. And just one comment I wanted to make here that when we are deciding the dose of gonadotropins in PCOS, so we have to keep their age and BMI also into consideration, right?
Definitely. I agree with you.
A young and a thin patient, you can start with something like 37.5, but an older and obese patient should be started with something like 75.
75. I do agree with that.
Yeah,
Definitely.
so that has to be kept in mind. Thank you so much, Dr. Renu.
Thank you. Thank you.
So I think the first session ended. Now with the second session.
One more talk, ma'am.
Bhavani, can you?
Oh yes, the second adjuvants in PCOS. Dr. Neelam Bapna.
Bhavani, Shivam, is she able to share?
I have shared the screen, but it is not showing. From my side, I am trying to share it.
Maybe you can stop sharing your screen, Bhavani. We can invite Dr. Neelam Bapna. Dr. Neelam Bapna is the co-convener of SIG PCOS, and she was the secretary earlier of the Rajasthan chapter of IFS. Bhavani, you stop sharing. Dr. Neelam, are you there?
I've stopped sharing.
Dr. Neelam? Shivam, can you see if she's unmuted or not?
No, she's unmuted. Yes.
Dr. Neelam?
I'll call her up.
Yeah, even Dr. Malvika was also saying that there is some problem with the Zoom platform, Shivam. Even
Ma'am joined. Ma'am joined.
She's not.
Dr. Neelam is here.
Yeah, so Dr. Neelam is the consultant obstetrician and gynecologist, Shivani Fertility and IVF Center, Saket Hospital, Jaipur. A very dear person, and we are lucky to have her in our SIG PCOS as a co-convener. So Dr. Neelam would be speaking on adjuvants in PCOS. Dr. Neelam, you can start sharing your screen. Meanwhile, Shivam, you can talk to Dr. Malvika. I don't know what problem is she facing in the Zoom platform.
Okay, ma'am. Done.
Dr. Neelam, can you share the screen?
Malvika ma'am joined.
I don't know whether Dr. Neelam can hear us.
Am I audible now?
Yes,
Yeah,
yes.
we can hear you now. Can you share your screen also, Dr. Neelam?
Shivam, have you given the screen share?
Yes, ma'am. All the rights have been given. Maybe शायद उनका इंटरनेट नहीं चल रहा.
Okay.
जी.
Dr. Neela, Dr. Picky, maybe we can talk to
I'll
her.
call her. I'll call her.
Otherwise, we can go on with our panel and she can have
Yeah.
the talk.
Yes.
I can see her. Aho. ठीक है.
Yes, yes.
We can see your slides now, Dr. Neelam.
Yeah, we can see her. But we can't hear her voice.
Dr. Neelam, are you speaking?
No, ma'am. She's not. Maybe her internet connection is not good. Yeah. She's unmuted now.
Yeah. Am I audible now?
Yeah. Yeah, ma'am.
Yes,
I
yes,
audible?
Dr. Neelam. Yes, yes, Dr. Neelam. Welcome. Please start, Dr. Neelam.
Yes. Yes.
Dr. Neelam, there is some problem in your internet.
And your voice, we are not able to hear and it's breaking.
So,
You need to go to an area, Dr. Neelam, where the internet connection is good.
Dr. Neeti, let us start with the panel. Dr. Neelam is at a place where the connectivity is not good. So after this panel, she will give her talk.
Okay. So I will be sharing the screen now. Let me just. Can you see my?
Yes, yes.
Okay. Okay, so we will be discussing, this panel is on managing tricky situation in ovulation induction in PCOS, and I invite, all our audience also to give their inputs, to ask any questions if they have, because these are some situations which we encounter in our day-to-day practice. So this panel I will be moderating along with Dr. Parul Garg, who is the co-convener with me, Dr. Bhavani. Dr.
Yes,
Bhavani,
ma'am.
can you just introduce Dr. Parul?
Ma'am, you'll have to allow me to share my screen.
Let me just then stop sharing, maybe.
it's okay, ma'am. We can continue.
Yeah. I think I've shared. Is my screen visible?
Yeah. So you can share this CVs of the
Not here,
panel.
Dr. Bhavani, your screen is not visible.
Your screen is not visible, Bhavani.
I'll just introduce Dr. Parul. Dr. Parul Garg, co-convener for this SIG, is presently working as head of Department of Reproductive Medicine at Artemis Hospital, Gurgaon.
Can you introduce the panelists also then, because I can't.
Yes.
You can't share your screen, Bhavani.
I'm sharing it from my end, but it is showing your screen sharing is paused.
Just stop sharing and then share again, Dr. Bhavani. Please try that.
Can you share now?
Trying, ma'am.
Okay, then you can introduce. Okay, no, it doesn't matter.
Not
You introduce the panelists then.
Dr. Neeti can share the PPT and Dr. Bhavani can just say it out.
Actually, I don't have the PPT, that thing, which
Koi
has the
baat
panel. But she can just speak out the names and the affiliations. Bhavani, you stop sharing. I will share my screen now. Bhavani?
Ma'am, I'm not sharing.
Just speak out, Dr. Bhavani. Just speak out. Introduce all this.
Introduce her.
Okay, I'll just introduce. So the first panelist is Dr. Shweta Mittal Gupta. Ma'am is Senior Consultant, Co-Director and Unit Head, Center of IVF and Human Reproduction, Sagangaram Hospital, and also General Secretary, IFS. Dr. Picky Saxena. Ma'am is Head of Department, Obs and Gynae, Lady Harding Medical
Not
College.
head of the department, Dr. Bhavani.
Sorry.
I'm unit head.
Director Professor.
Director Professor, Obs Gynae, Lady Harding Medical College. Dr. Malvika Mishra. She is a senior obstetrician gynecologist and reproductive medicine specialist, professor and nodal officer, reproductive medicine, RML Hospital, Lucknow. Dr. Renu Makkar, she is director, Makkar IVF Center, Lucknow. Dr. Vaishali Jain, she is director and founder, Diva IVF and Fertility Clinic, Lucknow. Dr. Shalini Raman. Dr. Shalini Raman is director, Brajraj Test Tube Baby Center, Lucknow. Myself, Dr. Bhavani, associate consultant at Sagangaram Hospital. Dr. Sakshi Nair, also associate consultant at Center of IVF and Human Reproduction, Sagangaram Hospital.
Thank you so much, Bhavani. So we have, a very bright group of experts who are sitting as panelists in this panel today. Unfortunately, I don't know why Dr. Shweta might not be here now because she had to leave and she had a flight. So she might not be able to join, and Dr. Vaishali is probably in an emergency surgery. But we have other bright panelists, so we will continue with our panel. So going on to case 1, which will be taken up by Dr. Parul Garg.
So I welcome all our panelists. So this case 1 is Mrs. X, 28 years, and Mr. Y, 30 years, and they are married for 4 years and trying to conceive since 3 years. And menstrual history is lasting for 4 to 5 days, and it occurs at every 2 to 3 months since the age of menarche, that is 12 years. And she often takes withdrawal treatment. And she also complains of coarse dark hair growth on the face and lower abdomen and arms, which has progressively increased over the last 2 to 3 years. And she also complains of worsening acne on the face and back. Family histories, mother is diabetic. BMI is 32, BP is normal. Apart from acne and hirsutism, she also has a acanthosis nigricans. AMH is 6.8 nanograms per ml. HbA1c was 5.9%. Lipid profile was normal. TSH prolactin levels were normal range. Tubal patency test is normal. Semen analysis report is normal. Ultrasound pelvis uterus is normal. Both ovaries show PCOS picture, and AFC is almost more than 20. She has tried 3 cycles of letrozole. First cycle was with 2.5 milligram, and next 2 cycles with 5 milligram for 5 days. So there is no ovulation. So how will you manage her? And can you have next slide, please? So this is a letrozole resistance. So what is the role of lifestyle modification? Dr. Malvika, ma'am.
So definitely she is obese, and lifestyle modification has a major role to play here. And I would want her to reduce weight, and that is definitely going to increase her chance for ovulation. And once the weight reduces, the most of my patients, they start responding to letrozole and ovulation induction agents. So that is one thing I would want to actually achieve before even I start ovulation induction for her, or maybe that should be hand in hand, parallel. Both the things are taken up if they are very desperate for pregnancy and ovulation induction. I would like to add metformin here because in my experience, and there are studies also, that it increases the chances of ovulation for the patient. Clomiphene citrate per se, I generally avoid in patients with PCOS because mostly letrozole, weight reduction, and if this fails, I go step up to gonadotropins. So that's what I want to say in this case.
Dr. Malvika, is it possible for you to switch on your video? We would like to see you also.
Okay. I'm just back from the hospital, barely,
You would look pretty any which way. So,
Ma'am, is there any role of inositol?
See you. Hi.
Yeah, hi.
Hello, seriously, I've just come back from the hospital, dead time.
You look as fresh as the morning.
Hello? Can you hear me?
Is there any role of inositol?
Inositol, yes. It is one of those adjuvant drugs that all of us are using. But what difference I see that metformin is really giving us better results in PCOS than inositol. And lifestyle modification has a very clear positive effect of on ovulation induction.
Yes, ma'am. Yes, correctly. Ma'am, can we have evidence? Next slide, please.
Even a 5% reduction in
Yeah,
weight.
I am about to say.
Okay,
So
okay.
there is a combination of excess weight and PCOS which adversely affects reproduction and metabolic and psychological health. And insulin resistance affects the 75% of lean women and 95% of those with BMI more than 25, the PCOS. Overall, the PCOS plus excess weight, if we have a lifestyle intervention and we reduce the total weight as little as 5%, it has shown the metabolic, reproductive, and psychological benefits. And what the evidence-based studies say on the PCOS 2023, they are the behavioral strategies that we should have a goal setting, self-monitoring, problem solving, which can optimize the weight management. And we also have a next slide, please, ma'am. Dietary intervention, there is no evidence we should have one type of diet composition. We should have a balanced, healthy diet which helps in reduction of the weight. And thirdly is the exercise intervention. It should be a combination of moderate intensity activity as well as the vigorous intensity aerobic activity plus the strengthening activity, which helps in reduction of weight and also maintenance of weight reduction. Now, as far as the role of
Can
metformin
we
versus
ask other
inositol.
panelists also, someone else also has something to say about metformin versus
Okay.
inositol? Any other panelist?
So this is a
Okay, Nikita.
PCOS type A phenotype because she has high BMI, she has irregular cycles, she has hirsutism, and she has PCO morphology. And also she has a high BMI, which we can see, and she's a pre-diabetic with HbA1c more than 5.9%. She has hirsutism. She has increased insulin resistance, which is evident by hirsutism and also acanthosis. So metformin has got a very, very important role in stabilizing the metabolic derangements. So I think metformin will be a very, very good drug because it will reduce the insulin resistance, which will decrease the hyperandrogenemia also and correct the follicle. The LH ratios will come down, FSH will increase, and she obviously it is not used singly as a ovulation induction drug, but as the metabolic problems are going to come down, she has a better chance to respond to most of the oral ovulations.
I have one question: whether you should add the metformin in all the PCOS patients, irrespective of BMI.
So we can add, actually the recent guidelines say that we can add even in lean PCOS, but especially if there is impaired glucose tolerance, impaired fasting, or like this patient, you have got a HbA1c which is in the pre-diabetic, or she's obese and hyperandrogenic, or she has surrogate markers of insulin resistance like acanthosis, increased BMI, waist hip ratio is more, or she has metabolic syndrome. So in all those conditions, I think even in lean PCOS, we can add.
Yeah,
And what about inositol? What about inositol?
Inositols are also the other option. If the patient, actually, Dr. Neeti, the best thing is metformin because the cost is low. But because it is a drug, especially in younger patients, you can't give for a long time. And some patients have GI disturbances which do not settle with metformin. So inositol is a food supplement which has been approved by FSSAI and it is quite safe. In normal patients, the ratio of myoinositol to D-charanositol is about 100:1. So inositol is also a good alternative because it is going to help in the recruitment of the follicles and make the follicles mature. It brings down insulin resistance and also reduces hyperandrogenism.
So
But
patients are not tolerant. We will think of
even
basically,
I don't think
metformin
as well as metformin. Metformin is definitely the first choice and robust.
first choice, yeah. So what the difference between the two? Metformin has a high side effects like GI side effects, If it is not there, then we go to inositol. And as a evidence-based study, metformin is the first line, and inositol is under research. And
Metformin will also help in weight reduction for the patient. This is one major advantage that I feel that it
this
has.
is
So
yes,
this
this is
patient, we are definitely wanting a lifestyle modification. So it serves both our purposes.
so we
And
can
then
consider
people
the
become more
metformin.
compliant when they know they have a medicine that will help them reduce weight also.
Yes,
Their skin
metformin.
becomes better, everything, all the parameters start becoming better. And the other advantage is that it will prevent OHSS to some extent. So in that way also, if we are planning ovulation induction, and the dose which we are going to give to these patients, especially if they are obese, which will be more, as Dr. Neeti had said in the beginning, if she's obese, higher BMI is there, then in these patients especially, it is very useful.
So we have planned for the starting of metformin. Dr. Renu, what are the parameters? What do you think when you start with the metformin? What are the things we have to consider when we are starting the metformin? Dr. Renu?
Before starting metformin, first of all, we have to see her body mass index. How much is the dose required? So if she is very obese, then we can start with a higher dose, or maybe we can start with a lower dose if she is not able to tolerate. With the time, she'll be able to tolerate. Second thing is, I always advise in my practice to take it in between the meals. Suppose she has to take rotis, then I say take one roti and then another, then the tablet and then another roti. So that way the GI side effects are less. Serum creatinine and LFT, definitely we have to get it done before starting.
Yeah, we start with as the BMI either with the 500 milligram or 1 grams, and we increase the dose every 1 to 2 weeks, and maximum dose is 2.5 grams in adults. And this may be associated with low vitamin B12 levels, especially in the risk factors for low vitamin B12 like diabetes, post bariatric surgery, pernicious anemia, and vegan diet, where monitoring should be considered.
The thing is, you don't have to monitor much. They can take it for 1 or 2 months and they may respond.
And the good thing is that it does not cause hypoglycemia. So there is no chance. And depending on the blood sugar levels initially, we can increase the dose as Dr. Renu has just suggested. So sustained release tablets are also a good option. What Dr. Renu has said is really practically I've seen very useful, that they take it in between meals, and sustained release also reduces GI side effects to a great extent.
Hypoglycemia is very, very rare with metformin.
It is not there because it is an insulin sensitizer. It is not going to reduce, cause hypoglycemia.
Sometimes patients, they do come with, especially with GDM, when we are prescribing metformin, they do come with chakkar aa gaya, gir gaye kind of thing. And but what we feel, it is more of they have read the leaflet of the tablet, or maybe they have read it on, then they feel that they are having the low BP or low glucose levels kind of thing. But most of them, they tolerate really well. Even the young girls, they tolerate it really well.
And we must take time to counsel these patients, because when they go to the chemist is going to tell them that this is an anti-diabetic drug. So we have to take time, counsel the patient properly, that this is being given for what purpose. The risks and the benefits need to be told to the patient, and then only slowly increase in small increase.
This is very important, counseling about the intake of tab metformin.
And also about GI side effects, that it will be there in the beginning, but it will slowly come better with time.
So next question. Now, what are the other treatment options? We have lifestyle modification. We have add the adjuvants. Now, patient letrozole resistance. What is the next line of treatment? Dr. Shalini? Is she there?
Dr. Shalini Raman. She was there, I think.
Can I?
Dr.
Renu, please.
Yeah, please, Dr. Renu.
The second option is we can add oral ovulogents or maybe gonadotropins. And if they are not ready for gonadotropins, then definitely surgical treatment can be done if the size of ovary is very large. But this patient is a type A PCOS, that is type 1 PCOS, where you have all the three there. And if there is, and in these cases, there is hardly any stroma. So most of the patients, they will have definitely more of few of the follicles. It is more of endogenization and the irregular cycles and anovulation, rather the size of the ovaries. Size of the ovaries may not be very high in these cases, and they are difficult to ovulate. Drilling in this patient is going to be really tough, because drilling may not give her much of effects, only lowering the androgen levels and improving her cycles, improving her weight, and then maybe a cycle of gonadotropin. And if the gonadotropin cycle is not helping her, I think this patient, because her AMH is very high, with this high AMH, I don't think she is going to respond very nicely to our even gonadotropins, because they don't respond to because the AMH is holding her follicles back, and then they don't respond. I have to do many times in patients with very high AMH, the donor cycles, because they hardly give you eggs, and most of them, they are having some kind of polymorphism. So
we will come to that, Dr.
We will come to
that in a while. We can ask other panelists also. No,
yeah, Dr. Bhavani.
Ma'am, I feel after this, I would switch over to gonadotropins. If
Yeah.
patient is not affording, then we can try clomiphene with metformin. But the first choice after this would be gonadotropin. And if not responding to gonadotropin, then maybe consider laparoscopic ovarian drilling.
Okay, fine. So we have a two second line of treatment, either gonadotropins or laparoscopy ovarian surgery. So
I would like to add a little experience here. So in a couple of my patients, I have used letrozole, and there were few studies for a prolonged duration. And to my delight and to patients' good outcome, they have conceived and I've had monofollicular developments with prolonged letrozole usage. So that has really worked. So that is one thing that I would try to do before I switch over to gonadotropin. Of course, gonadotropin is the next line of therapy once there is absolute resistance to letrozole.
Dr. Malvika, can you tell how did you give this extended letrozole?
So there are a few studies where you continue letrozole for maybe 14 days or 21 days. And gradually what you see, one follicle or two follicles being
How
recruited.
do you call them monitoring? How do you call them? Like you gave it for 5 days and then you call them for monitoring, add again, or?
Yeah, I gave it. Yeah. So I've had at least 4 or 5 such patients. And because again, I'm working in a, medical college, basically institute. So these patients who are non-affording, who cannot, directly go ahead for IVF maybe or gonadotropins. So I started using this protocol in these patients. And I have had really very good response with this kind of, prolonged letrozole usage. So I call them every 4th, 5th day, and then gradually you see one follicle coming up, and just there's beautiful monofollicular development happening. So
are you going with the same dose or you're increasing the letrozole?
Same dose. I'm not
same dose.
increasing any dose. Same dose. I'm going with the same dose. So this was an experience that I wanted to share so that other patients
So you
could
continue letrozole for 20-21 days?
Yeah, 20-21 days. I've had a couple of pregnancies with them, and there are studies. Then I read that, and gradually then I started using it. So there are monofollicular development is occurring with prolonged letrozole usage.
And what about clomiphene? Dr. Picky was talking about clomiphene, trying clomiphene in letrozole resistance.
I have not tried both clomiphene or letrozole, and basically in PCOS patients, I have found that I do not get very good results with clomiphene somehow. So letrozole is the drug of choice for me, and then if resistance, then switching over to gonadotropin, of course, that all of us are doing.
Ma'am, I will go with the clomiphene along with the metformin. If it will not work, then I will go with the gonadotropin injection.
See, it depends on the place where you are doing, if the patients are not affording, you can switch over to clomiphene with metformin, which also has a good effect. And if that also fails, then I go to gonadotrophins. And if the patient, actually it comes free in our hospital. So when it is available, we do try gonadotrophin. And in my experience, if there is failure with letrose, sometimes clomiphene with metformin really works. So it is not that metformin is, this clomiphene is totally useless. As Dr. Ruma showed, it shows a good response. Only thing is that we have to monitor very sincerely so that she doesn't develop too many follicles and prevent OHSS. And with metformin, the chances of OHSS will be lower. So that is not a totally out option. And another thing, this is phenotype A PCOS. So she is going to have a big hyperechoic stroma, and hyperandrogenism is already there. So if these things do not work, if the patient cannot afford gonadotrophin, she's not ready to come. In our hospital, sometimes the patient stays far away. She's not able to come for monitoring and all. In those patients, we do try LOD and it works.
Also, ma'am, in my practice, I've actually tried letrose 7.5 milligram as well. And sometimes in those patients who are resistant to 5 milligram, 7.5 milligram has actually worked.
Letrozole.
Letrozole.
You know, sometimes such high doses of letrozole
Yeah.
can have a very detrimental effect on endometrium.
Yes,
Absolutely. But in certain
it is an aromatase inhibitor. So
Yeah.
it will prevent conversion of androstenedione to estriol. So
Yeah.
androgen will increase mood. So maybe the endometrium may not be that good. That is why probably the regulatory bodies have not permitted the use of high doses of.
Yes, ma'am. But like
Yes,
I
ma'am.
was just telling you about my experience also that I have given, because in the literature they have told
Yes.
about letrose at 2.5, 5, and 7.5. They have given incremental dose. So I've just tried 7.5. Those who have not responded to either, and they are big, like heavyweight patients.
Right.
In those cases, they have responded.
So these studies are already shown by Dr. Renu ma'am in their representation. So should I repeat this?
No.
So next question, when do you consider laparoscopy ovarian drilling? Dr.
Practice, you can tell us one by one.
Dr. Shalini?
Yes, ma'am. If the patient is not responding to the letrozole and the clomiphene, then I will like to go with the laparoscopic ovarian drilling. And she might be have an hyperandrogenic feature like obesity and acanthosis nigricans, hirsutism, acne, and not responding to oral ovulation. Then I will go with the and not responding to the also the gonadotropin, then I will go with the laparoscopic ovarian drilling.
Okay. Dr. Malvika?
Dr. Niti, to be very honest, I have almost stopped doing laparoscopic ovarian drilling for a long time now because I don't see any advantage. Most patients are generally, you know, then getting converted to IVF cycles, and we need a good ovarian reserve. So rarely I'm doing laparoscopic ovarian drilling now. But yes, if the patient is absolutely not going in for IVF and there is very high LH, then that can be an option.
I feel when the evaluation of pelvis is required, then we think of doing laparoscopy ovarian drilling. And they may be the
Along with
cost.
some other surgery, along with
Yeah.
some other indication.
Along with
Some other indication, then we go for laparoscopy.
Or if the response to gonadotropin is very erratic, unpredictable, in those
Then you
cases
can, yeah.
also we can consider.
If she has had previous episodes of OHSS or multiple pregnancy, or she's staying far away, she cannot afford, and all other methods have not worked for her, then we need to counsel her again that because of this, post-operative adhesions can form, and an expert person should do it. Only 4 punctures, 4 millimeters deep. 4 is the amount of cautery which is to be used. And after that, a thorough lavage should be done. So all those things, and AFC may come down, the AMH may come down after that. Explaining everything, then only we should decide for the, take a shared decision making for this procedure.
Yeah, sure.
Can I add something to this, Vicky?
Yes, ma'am.
Yes, please.
I
Yes,
have patients, they are very sensitive to estradiol levels. The moment you start stimulating, day 1, day 2 even, they have very high liver function derangement. And then it is very difficult to stimulate them. I had one patient where I had to stop inducing her. Once she was stimulated at Dubai, they failed to stimulate her. They had sent her back to India. She came here. I thought, let me stimulate this patient. Immediately started having very high LFT changes. Then I had to do drilling, and with that drilling, she conceived. So these are few cases where you have patients have very high sensitivity to gonadotropins or even oral ovulogins. Then they can conceive spontaneously with this ovarian drilling. Or
Actually, please.
You add. Continue, Dr. Piki.
Actually, we had stopped doing ovarian drilling, but recently Dr. Reena, madam, in our hospital did a thesis on this, and she got very good results. There was a high clinical pregnancy rate with ovarian drilling. So in between, we had just stopped doing because it reduces ovarian reserve and post-op adhesions are also there. But now, again, I think they have rightly put it as the second option with gonadotropins if the oral ovulogins are, if letrosis.
There is a lot of evidence coming up. People have tried even single ovarian drilling, because what we know from our experience of 5 years, the right ovary ovulates better. Right ovary gives us better oocyte quality. Left ovary is always responding with less number because of the anatomical position and ovarian supply. So most of the patients, they do only one-sided ovarian drilling. Because whenever we are drilling the ovary, because we started drilling ovary when there was no option, when the NTAGs were not there. Now we have NTAGs, we can always do IVF. Patients also will be afraid. अगर किसी को बोलो कि मुझे तुम्हारी ovary में drill करना, nowadays they will go on Google and search everything about drilling, and then they will have all those negative points about the drilling. Obviously, when we were doing it, it was definitely giving us results, and used to work for a year at least. So that was the thing. Nowadays, I don't think anybody is doing it, or those who are doing it, they are really maybe in a desperate situations, like I said, like when it's a huge ovary, it has to be a really huge ovary, not beyond 35, not less than 3 years of infertility. So if it is more than 3 years of infertility, I will never do it.
So this becoming a less popular now. Gonadotropins has been
actually, it's a one-time procedure. It has
one time.
Don't have to follow up the patient so
but it's invasive. But it's invasive.
It is invasive, but it is if all the three things are failing, then
we can think
and
of.
if the patient cannot afford gonadotropins, then it is an option. Of course, it is not a first line option, but it is given as a second line.
Yes, sure. And then next question. So after counseling the patient, ovarian stimulation with gonadotropins were decided in the next cycle. So any benefits of type of gonadotropins, HMG versus recombinant? It has already been discussed. Dr. Sakshi?
Yeah, as Dr. Renu, you've told us that there is no difference between whether you go for urinary or whether you go for recombinant. So it doesn't really matter. You can go with anyone.
But with the recombinant, one more advantage, it's we can titrate the dose. That is not.
Yes, you can titrate the dose, but honestly, if you're asking what the effects, and especially in PCOS or in any other patient, doesn't really matter, whether with whatever we use.
Yeah, and Dr. Malvika?
Yes, I think it is equally efficient, and earlier there was the thing that we were using recombinant, but I think that has long been done with, and using the recombinant HMG is fine.
But sometimes due to the batch to batch variability, we do not get a response with urinary HMG.
And
we have to weigh the cost and the benefits. So if the patient can afford and she's not getting the response with HMG urinary or highly purified, then I
Then
think
we
if the
prefer the
patient can afford, it's a good idea because batch to batch consistency, the dose you are very sure of. But in our public sector hospitals, patients cannot afford, and HMG is a good enough option according to all the evidence also.
Can I add something, Dr. Picky, here?
Sure, ma'am.
Yeah, it's regarding HMG and recombinants. Recombinants, they definitely give you follicles much earlier as compared to HMG. The quality oocytes, they are better with recombinant. But with HMG, what we have seen is the implantation rate is better. You may get good quality oocytes with recombinants, but if you have HMG, then implantation does definitely better. You may have to stimulate for a few more days, but endometrium is definitely better with HMG. This is my experience.
Fine. So can
You
you?
know, as far as Parul, as far as titration of dose is concerned, when we earlier we were bothered about this, that with recombinant only you can have smaller doses like 50 units, 2.5. But you know, now we have these multi-dose HMG.
Yeah, multi-dose HMG. Yeah.
Vials are there.
Pen is
Pens are there. Pen
pen
and
are
bulk.
there. Then we can titrate with that.
You can
That
titrate
problem
from
is done with.
37.5 onwards.
So you can
So-
have smaller doses of HMG also if you want to give 37.5, 50 can be given, right?
And Dr. Renu showed us the evidence, and Dr. Parul was also showing that they have equal efficacy for clinical pregnancy rate, abortions, and multifetal pregnancy.
Yes,
So,
yes.
yeah.
So what protocol will you use and what will be the starting dose? Anyone can take the answer. The question, please.
We will start with low dose step up protocol. Since she's an obese BMI 32, we'll start, most likely I'll start with an like a urinary component HMG with 75 international units. And then I'll, after giving 4-5 days, then do an ultrasound and then do a step up.
I think this already been discussed by Dr. Renu ma'am. This is a low dose step up regime in which we increase the dose every 7 days till we find a dominant follicle more than 10 mm. And the rationale is to have a monofollicle growth and minimize the multiple pregnancy and allow the slow rise of FSH just above the threshold and avoid the explosive ovarian response. And then other regimes like chronic low dose in which we increase the dose after 14 days and after that every 7 days till the dominant follicle is there. Then we have a step down. This already been discussed with Dr. Renu ma'am in their presentation.
Dr. Neetu, can I ask a question here? When
Sure.
we are giving gonadotrophins in these chronic low dose and low dose step up wala thing, then are you not getting estradiol levels done?
You know, there are certain indications of doing estradiol when you are giving gonadotropins. Okay, in two situations you have to do estradiol. One is when you are seeing a lot of response, lot of medium sized follicles also coming up, and you're not sure and you want to cancel the cycle, or when you are suspecting a hyperstimulation, then you do estradiol levels. Or on the other hand, if you're not seeing any response, you're not seeing any dominant follicle coming up, but there are a lot of small follicles which are there. So in that case also you will, think of doing estradiol and see whether sometimes estradiol tells you, that the response is going to come. Just wait.
Yes,
Wait at the
yes.
same dose. Wait
So
at the same dose. Don't increase.
yeah, definitely. I think that is very important to see. If the estradiol is rising, maybe the follicles will also come up.
Will come up. So don't increase.
They come up. So it's a
Basically,
good
yeah.
idea to do estradiol levels at
It
least.
will tell our response is going okay.
Yes. You don't need to increase the dose.
Increase the dose, right. So this already been discussed. Now in this cycle, we have given the injection FSH 75 units for 7 days. There is no response. And this increase every 5 days and maximum dose for 225 units and there is no response. So what next? This is basically a gonadotropin resistance.
Have now been given, basically we have done a low dose step up, right? And we have gone up to 225 unit. We have given 225 also for 5 days and nothing has happened. So what is the next step? Dr. Picky.
She could be a case of FSH polymorphism. And because she's obese, she had a high BMI, she had a high IMH, AFC was also high. So we need to look on those lines. So there are two things that we can do. Either we can switch over to HMG because that sometimes works, or we can increase the dose. But that has to be weighed and very carefully it has to be done. Along with that, we have to see if she has any other problem. If she has severe hirsutism or hyperandrogenism, it is a good idea, I think, that sometimes you can give OCs or anti-androgens for some time and reduce her weight, give metformin for some time, it will come down. Or if she is having hyperprolactinemia, capgulin can be given for some time. And sometimes we can add dexamethasone also. So all these options are there depending on the situation. We need to act. HMG, I think, can be given in patients who are not responding to it. And polymorphism, if FSH, what was the FSH level of this patient, Dr. Parul?
If FSH, we usually not doing in the patients. In the
no, but baseline, if you are doing, it's a good idea. If the patient is having very high AMH, BMI,
high AMH, IFS, FSH,
and FSH is slightly high, those patients are probably going to land up in this non-response type of case.
non-responsive. And apart from the receptor polymorphism, there is also role of investigation like 17-hydroxyprogesterone to rule out congenital adrenal hyperplasia, where the steroids can be required, and also the level of serum dehydroepiandrosterone. If higher, if it is higher, then we can consider dexamethasone.
We should not forget this patient was quite androgenic to begin with, no? She was quite androgenic. So maybe these could be the reasons.
And dexamethasone can be tried from day 5 to 14, I generally give. And how it helps is probably if DHEAS is high, that is adrenal is secreting this, so it will bring it down. Another thing is that it helps in the action of FSH. And also it reduces some cytokines and potentiates growth hormone. So it helps in folliculogenesis. In few cases, it may be useful. I've seen some of the private practitioners also giving, and sometimes I also give. And especially if she has associated anti-sperm antibody positive, the sperms are having the agglutination is there. So in those cases also, DEXA has a role.
So what is the dose, Dr. Piki, you are giving of dexamethasone in resistant PCOS?
See, it is written in the books 2 milligrams, but I give 0.5 only.
0.5.
And I tell them to take it at 11 o'clock in the night. And they take it from 5th day to 14th day generally.
14.
Because it is not a good idea to give for a long time because they will gain weight, Cushing syndrome like things will come, and blood sugars also become deranged. So that has been tried. But books and the evidence, I think they say 2 milligram is the dose.
I agree with Dr. Picky because even I am using only 0.5 and it gives a better mature follicle.
Yes, yes.
Cases. That is very true.
So we have a role of dexamethasone in resistant PCOS with the normal DHEAS levels. So there are studies also which show the improved ovulation rate as well as the pregnancy rate if we use a dexamethasone. So some studies use 2 milligram and some studies have also used 0.5 milligram.
Okay.
And it starts from day 5 to day 9 or from day 5 to till 14 day also. These are the various studies. And they have also tried this combination of dexamethasone in the letrozole resistance also. In this, they have basically given 2.5 milligram for 5 days, and then on 10th day, they have found no dominant follicle. They increase the dose from letrozole 2.5 to 5 milligram for 5 days. Still no dominant follicle. Then they increase the dose to 7.5 milligram. Along with that, they have given the dexamethasone 0.5 milligram for 7 days. And then they found a dominant follicle. So they found that there is an increased ovulation rate, but the pregnancy rates are similar.
In this scenario, ma'am, we can consider ovarian drilling also.
Yes.
Yes.
That will be a good option if other things are not working.
So the gonadotropin resistant cases are very tough to handle. And it often happens that people get frustrated, as Dr. Renu Makkar was also talking about, that when you get gonadotropin resistance, even with 300 units, you might not be able to get a ovulation happening there. People think of, going on to donor oocytes in PCOS. And it is very strange. These women have such good reserve and we are going on to donor oocytes. So it is very important that we try these strategies, like giving, maybe dexamethasone or doing a drilling like Dr. Pani mentioned, rather than jumping onto, and most importantly, reduce weight, reduction of weight. Tell her to wait for some time, maybe 3 months, come with a reduced weight, do a ovarian drilling and try again, rather than jumping onto donor oocytes in a patient of PCOS, right? Any other comment on this case from any other panelist? These are like real life scenarios which we are discussing. And way back, when I started my practice, I had such a patient, very obese South Indian female who, and this is her history, kind of similar this history. And I was like thinking what to do, and after 200-300 units she stopped coming to me only, and she came after 2 years with 2 children in both her arms, and she had gone to some other center. They had given her donor oocyte. So she had gone to some other center. She said, ma'am, आप तो कुछ कर नहीं पाए, उन्होंने मेरा donor X से कर दिया IVF. So yeah, so this is the real life scenarios which we often encounter. Now coming to case 2. So case 2 is Mrs. M, 32 years, and Mr. N, 35 years, are trying to conceive for 2 years. Menstrual history 4 to 5 days, 40 to 50 days, irregular. Her past history, she was diagnosed as PCOS and underwent ovulation induction with clomiphene 100 milligram for 4 cycles. Ovulation was documented in each cycle, and in the last cycle, she also underwent IUI with ovulation induction. Her BMI is 26 kg per meter square, but there are no signs of hirsutism per se. On investigations, her AMH is 7.2 nanogram per ml. Her GTT is normal, lipid profile is normal. So unlike our previous patient, this patient looks like metabolically normal. Her ultrasound shows normal uterus, bilateral ovaries are PCO, and on HSG, bilateral spill is present, and husband semen analysis is normal. So basically, she is a case of clomiphene failure, where clomiphene is not kind of working for this patient despite ovulation. So, Dr. Sakshi, what will be your plan for her now?
So, ma'am, agreed that she's ovulated with clomiphene and she's done it for 4 cycles, but if it does not work with oral ovulogens, so my next method will be I'll give her gonadotropin for ovulation, and along with that I'll do an IUI for another 2-3 cycles.
So, Dr. Bhavani, when we do ovulation induction with gonadotropins, what specific counseling is required in a patient of PCOS? And how should we document it in the case, in an era of medico-legal implications coming up on doctors? What counseling and how should we document it?
It is important to counsel the patient about the cost, the frequent monitoring gonadotropins will require, and also about the side effects like multiple pregnancy and ovarian hyperstimulation.
And anything else, Dr. Picky, you can think of in counseling?
I think
when you start gonadotropin,
we have to tell her it is extremely important that she has to visit us. We should tell her that we may get an exaggerated response or a failure of response also. And another thing is that
but a cycle cancellation might be required,
cycle
right?
cancellation.
That is what also I was going to say, that she might make multiple follicles and we might have to cancel the cycle.
Cost involved, there is daily injection involved, cost involved, and despite that, we might have to cancel her cycle. So
or convert it to IVF if required.
Yeah,
so all those options need to be told. She must have that much of money, or she should go to a center where IVF is also possible. All those things, if she can if the patient and her husband need to be counseled before
Do you
we.
think then in that case, gonadotropins cannot be started at centers who do not have IVF?
It can be started, but we should be, if she should be able to afford, if she's not willing to for cancellation, either she should be willing for cancellation or we can refer her to a center where she can have an IVF. That option can be given because patients don't like if the cycle is cancelled. And they feel it's very good, they have so many eggs. So both way the counseling should be done, that we may have to cancel, we may have to freeze all if IVF and freeze all, or she may have to be given a lot of drugs, avoid intercourse at that time, and all those types of things should be told. Cost and painful injections, that also, and she has to come every day. In our hospital, they generally come to the hospital and get the injections. All those things have to be told to her.
So after detailed counseling, we took her up for ovulation induction with gonadotropins and IUI. So started with injection FSH, and after 5 days, we were glad to see one 12 millimeter follicle on the right side and a 111 millimeter on the left side. So we continued with the same dose, thinking that these follicles will grow by 4 days. But when on the day 12 she came back to us, there was no growth basically in the follicles on both the sides. So basically, she has gone into follicular stagnation. So we just discussed it beforehand only that there could be a role of hormonal testing when these kind of things happen. So if follicular stagnation happens, Dr. Shalini, are you there? So what do you do? Do you change the gonadotropin? Do you increase the dose? What do you do? Follicular stagnation has happened.
Ma'am, I will increase the dose.
Okay. And will you do you generally go with the same gonadotropin or do you change the gonadotropin also?
We can change.
You can think of changing. Dr. Malvika, what do you do in your practice?
So yes, this is a very typical case we come across in our OPDs. This is a very common scenario. Patient has already been stimulated, and definitely I would want to increase the dose and maybe now add HMG here with increased dosage and see if she's responding. If not, of course, after 5-6 days of further stimulation, or maybe if I call her after 3 days and the follicles don't grow, then I cancel the cycle and call her to start with a higher dose in the next.
Okay. Dr. Renu, anything you want to suggest here? Anything different? Dr. Renu?
I don't think anything different
you want to suggest?
We can try a few more days of stimulation just to see how she responds for the next cycle. That is what I will do, because if you see on 16th day, you say that she has, like you have, on increasing the dose, you have got the follicles.
Yeah, that I'm just coming back to. So, we decided to change, and in my practice, I have often seen that even PCO, though we say that PCOS have high LH, they sometimes respond better to HMG as
Yes.
compared to FSH, right? So I decided to change to HMG and I increase the dose also. So I made it HMG 150 unit for 4 days. And on 16th day, this is the response I got. So Dr. Bhavani, what do you think has gone wrong in this case now? And what will be our next step?
This patient has hyperstimulated, as we can see that there are more than 2 dominant follicles, which we did not desire. So she has definitely.
Why do you think this has happened? That she was follicular stagnated earlier and now she's, after 4 days only, she has so many follicles there.
Probably because we have changed the gonadotropin and increased the dose also substantially, that suddenly she has hyperstimulated.
Okay.
We could have probably gone for a smaller increment in the dose and called her in another 3 days or so.
So maybe if you could have given maybe 100 unit or
Yeah, smaller increments would be much better
increment would have been better.
because they have already crossed the FSS threshold and they may cross the ceiling also suddenly.
All the follicles probably had a similar threshold and they have all
Yes.
crossed together,
All
and
crossed together.
what has happened. So Dr. Sakshi, when do you cancel the cycle in your practice?
So
If there are more than 2 dominant follicles, then I generally prefer to cancel the cycle because I don't want more than multiple, not more than twins, to be very honest. So generally, I cancel the cycle when it is more than 2 follicles. Or if I don't want to cancel it, I generally counsel if I see number of follicles, and then I can always counsel them instead of canceling. We can go ahead to IVF, as Dr. Picky also suggested earlier.
So what is the problem in taking her up for IVF, Dr. Bhavani? Do you think this patient is good enough for IVF in this one?
No, I think in IVF we would get a suboptimal response because this patient is capable of, she's a PCO, she's capable of giving us more than the number of oocytes that we can see in this scenario she would be giving. So I would say that converting her to IVF in this case would be reducing her chances which she would otherwise have if she would directly go for IVF.
Yeah, so when we are converting to IVF also, we have to, discuss it out with the patient. You have to counsel them that yes, we can convert you to IVF, but we are not realizing your entire potential. She has such good AMH. If we would have started with a higher dose to begin with, rather than 75 units, she could have made more follicles and she would have a better response according to her AMH. So if we convert her at this point, and still if she agrees to be converted, we can definitely convert her to IVF. Any other opinion of any other panelist on this?
Dr. Neeti, we are doing IVF in this case as a salvage procedure. And we can stimulate her more so that more follicles will come and at least those 12, 13, 14 will become bigger. And this is giving at least her some chances rather than canceling. That gives a very negative and the patients are in despair if you suddenly cancel. So something is better than nothing. Both things, counseling should be done.
So
And
counseling can
let
be
the
done
patient decide.
either way. Counseling can be done either way, Dr. Picky, because till now the cost of gonadotropin is there. Once they go into IVF, the cost of IVF adds on, right? And if you get say 7-8 eggs in this patient, this is not a very good cycle for her. So counseling can go either way. You have to tell the whole situation to the patient.
Yes.
And then
Let them decide.
let them
And
decide.
in the beginning only, I said that we have to tell them if they can arrange that much of money for IVF. And we have a connection with some IVF center where it can be done. Telling them the pros and cons of all the things. If they would have, if they could have afford, they would have gone earlier only. But at least the cost of gonadotrophins will not go waste. She has taken gonadotrophins for 10 to 15 days already. So it is according to the patient's socioeconomic status and how we counsel them and how they take the counsel.
And there is one more, option which is mentioned in the literature, though I don't think so any of us are doing it, that you can aspirate some follicles and go ahead. So that is also another option where you can aspirate some follicles and then go ahead with IUI only. But that is just a thing which is mentioned in literature. No one is actually doing it in practice. But what I want to bring across in this slide is that you have to cancel the cycle if the follicles are 2 or more than 14 millimeter, and you have to look at the medium sized follicles also. So if you have one good 18 follicle sitting there and then maybe a 16 and you are happy, but just please see those trailing follicles also. If they are like 14 there are more follicles which are reaching 14 or above. You should think of canceling the cycle, because now it is in guidelines. This is 2023 guidelines. If your patient ends up with OHSs or multiple pregnancy like quadruplets, pentaplets, which were used to happen in the past, this would not be spared at today day and era. So one has to be very careful while giving gonadotropins and have very strict criteria of cancellation. And that's why the counseling of the patients before starting gonadotropins becomes so important.
I agree. And 14 millimeters, they have already crossed the threshold. How fast they are going to proceed to 18 millimeters?
You don't know.
It's very, very fast. So it's unpredictable. So it is important.
So Dr. Renu Tanwar also mentioned about the role of agonist trigger when she was talking about. Do you think there is any role of agonist trigger, Dr. Malvika, in IUI?
Agonist trigger basically it's like whenever we've overstimulated and we've not, been on the line where we want only 2 follicles for IUI, only in that situation when we have
Your voice is not clear, Dr. Malvika.
Can you hear me now?
Yeah, now we can hear. Yeah.
So only when you've taken up your patient for IUI and you're planning for IUI, you've somehow, miscalculated the doses and you've got more follicles than desired. And there is a risk of ovarian hyperstimulation. In those situations, only there's role for agonist trigger. Otherwise, there is no reason why we would want to do a agonist trigger in IUI cycles.
But anyway, we should refrain from going ahead when you have more follicles, no?
Yeah, that's what I'm saying. But somehow, if you
so where is the role of agonist trigger then?
It
Definitely.
reduces the risk of OHSs.
OHSs, prevent OHSs basically, and in return also multiple pregnancies. So that's what I'm saying. Once you've somehow miscalculated, you have to actually stop if you don't have a monofollicular or 2 follicles. If you have more than that. Somehow, if the patient has not come for follow-up sometimes and she's got 3, 4, 5 follicles, it does happen. Then you want to give an agonist trigger to prevent multiple pregnancies and OHSs.
It will not prevent multiple pregnancy, right?
No.
How will it prevent multiple pregnancy?
Only OHSs.
It will only prevent OHSs, but it will not prevent multiple.
Yeah,
pregnancies.
OHSs definitely.
Yeah. Okay. So the problem is with PCOS is that it is so difficult to get only 1 follicle or 2 follicles, but the guidelines have come that you have to limit yourself, and of course for your patient, not to even guidelines, for your patient safety, because now what is happening is that in our practice, because of the agonist trigger being widely used in IVF, we are not seeing any OHSs in patients of IVF, but we get referred patients who got IUI done and where they have ended up with OHSs, even with clomiphene like drugs, where the monitoring was not done properly, and they have been given HCG trigger with multiple follicles being there. So that is the background where we are seeing OHSs now, because the control is less in case of IUI cycle. So in IUI, in fact, it is very important to be very careful during ovarian stimulation. In IVF, it is easy because you can give agonist trigger and retrieve all the eggs and freeze all. Right? So now quickly we will go through this case 3. Case 3 is a very small case because I just came across this patient, so I added this case and I wanted to know the opinion of everyone on this. So this Mrs. N, 22-year-old, married for 2 years. She's keen to conceive, very young patient, and she has irregular cycles since menarche, and her BMI is 22 kg per meter square and no hirsutism. So she is non-androgenic and she is a thin PCO. Her AMH is 7 nanogram per ml. Semen analysis is normal, and ultrasound shows a uterus normal in size with bilateral PCO. So in this case, we started her on tablet letrozole 2.5 milligram from day 3 of her cycle for 5 days, and on day 12, to our surprise, with letrozole, she showed these many follicles. So on the right side, there was a 17, 16, 14 mm, and on the left side 18, 17 and 14 mm, and with an endometrium of 6.5. And because there were so many follicles, we got a serum estradiol done, which was only 46 picogram per ml. But we should remember that when we are giving letrozole, estradiol levels are very low. Yeah. So they will come low, but they do not tell you actually the growing follicles. They do not correspond to them. So how will you manage her now, Dr. Picky?
So again, we can see that there are more than 2 follicles, in fact, 3 and 3, 6 follicles. So the risk of OHSS has to be explained. Although the estradiol levels are not that high, each follicle we can think about 150 to 200 picograms of estradiol will be produced. And in this, we have to take all precautions that OHSS does not occur. So I will personally not give her a HCG trigger and tell her not to have a planned relationship with her husband, and will like to monitor, tell her about signs that she should keep herself very much hydrated And if she has a pain in abdomen and all those symptoms of decreased urine output or constipation or any problem, she should come to us. And if we have to still monitor her, how these follicles are going to behave. And if we feel that she's going to develop OHSS, we can give her cabergoline. Calcium is also said to be useful, or Antag can also be given. Letrose also has a role. So I will avoid intercourse and HCG trigger for this patient.
Dr. Renu, do you agree with this management? Or do you want to do something else in this?
Dr. Neeti, if there is a problem with the male, like it's a moderate male factor or sometimes even severe male factor, they want an IUI. So I can think of having more follicles with less number of some. Suppose I have very low post-wash count, like less than 5 or 5. I'm still planning for IUI because the patient doesn't agree to go for IVF. I can think of asking them to continue the sexual activity or maybe even IUI, because with severe male factor, we are not afraid of, because not every male is highly fertile. And most of the time, what we find in our clinic is 70 to 80%, maybe more than that, they are having some kind of subfertility. So looking at the male, I can allow them to go for IUI or maybe timed intercourse. What the literature says is even if you have 4 follicles or maybe till 4 follicles, if we allow them to go for the treatment with the proper counseling of multiple pregnancy and without the SCG, I mean we have to go for the GnRH trigger. So then it can be done with all the precautions, because even if the male factor is not there, sometimes patients, they do agree because maybe it is their last chance, maybe it is their last cycle, they are coming to us for IUI. They say आपने इतना पैसा खर्चा करा दिया, अब हम क्या करें, अब हमारे तो follicles भी बन गए हैं, अब हम क्या करें. So then we can think, and with the risk explained, we can still go for IUI, because what we have seen is even till 4 follicles, the twinning rate is not much. But more than 4, the twinning rate and even triplets can land up, then it is difficult. We have to be, whatever we do, it has to be a good counseling and in a written, on the written paper.
Okay. Dr. Malvika, you want to add anything in? Do you think you will do something different in this, or?
Dr. Niti, I think I would want to, this is the case where I would want a GnRH agonist trigger, and I would call her back on day 14 and see the follicles. Sometimes these 14, they will not grow, So as Dr. Renu said, we'll have maybe 4 follicles, give her a GnRH agonist trigger, do an IUI and follow her very closely. Her estradiol levels are not so high. She will probably have a good ET by day 14, and I would want to go ahead with an IUI.
But in case you are thinking that 14 will not grow, would you like to call her again maybe after 2 days to see if they have grown?
Yeah, that's what I said. I will call her after 2 days, and I would just want to see the sizes once again, and then give her a GnRH agonist trigger and go ahead with an IUI for her if possible.
Can I add something to this? Only point against this treatment, if it was my case, is her age. With this young age, and if maybe the husband is also very young, chances of
this is her first cycle.
very high.
First cycle.
So that will frankly, यही एक चीज रोकेगी मुझे. Otherwise, I really fail to cancel the cycles usually, because patients, they have spent so much money, we have spent so much time, but her young age is definitely going to stop me, because she is the one who can have triplet or quadruplets.
She is young, and she has only taken letrose. She has not been in gonadotropins, and she already has.
Cycle.
This is her first cycle, and 4 mature follicles are already there, and 2 are also growing up. So we need to follow up, and the guidelines say that more than 2 You should not allow them to progress for
We
IUI.
follow the guidelines. We have to. If she was older, like she was 34, 35.
Yeah, she's a very young patient and first cycle is there. And it is only letrose. So
And we know the horror stories of quadruplets,
yeah.
Dr. Recently we had a patient who came with after clomiphene induction from somewhere else. She was referred to us with quadruplets. She got it reduced to twins. Then the third one also demised. Then the fourth one was only carrying on. Then she had leaking at 18 weeks, and that also demised. And then the cleaning, and then the Asherman. So the stories, is sometimes with this one first stimulation, her whole obstetric history can go in a real bad shape. So that we have to remember that the triplets and quadruplets are a big complication.
Definitely.
Okay, so what will you do in her next cycle? Dr. Bhavani, what do you think you can do in her next cycle? So suppose we decided, we went with Dr. Picky's opinion, and we decided to cancel the cycle. And now what will you do in the next cycle? She came back again to you.
We can try metformin, though there is not much evidence but there is some evidence in lean PCO also. Maybe it will prevent hyperstimulation. So we can try pre-treatment with metformin.
So how long will you give it before trying again? Do you start metformin and letrozole together, or do you wait for some time? What do you do?
I will, in this case, probably give her pre-treatment with metformin for 2-3 months and then again stimulate her with letrozole only, 2.5.
Okay. Dr. Shalini, do you want to do something else in the next?
Ma'am, it could be case of empty follicle. I think because the estrogen level is very low and according to the number of follicle that are growing. So I
Dr.
would
Shalini, actually, because we have done a lot of stimulations with letrozole in IVF also, the E2 remains very low with letrozole. So that is why I brought this point here, that please don't go by the E2 levels in a letrozole stimulated cycles.
Yes.
In IVF cycles, we have retrieved 10, 10, 12, 12 eggs with 400 E2. So we finally to where we give letrozole for 5 milligram or 7.5 milligram along with gonadotropins 150 unit, and we have retrieved 10 to 12 eggs, and the E2 till the end has been 400, 500. So please don't go by the E2 levels. The E2 levels are very misleading in a letrozole cycle. Anything else, Sakshi, you can think of in this? What will you do in the next cycle, Sakshi? Dr. Picky?
Same as Dr. Bhavani, I think lifestyle management, metformin, 3 months and then start her with letrose.
So
But
she's
very
already
careful.
thin, but we can try that, right?
Yes, metformin will definitely prevent, it will not prevent multiple pregnancy, but risk of OHSS will be down. And probably her hyperandrogenic status and all those things will come down with metformin. As we discussed earlier, all those benefits will be there.
Yeah.
Dr. Sakshi, are you there?
Yeah, I'm there actually. I was not able to unmute myself, but that's why I've come with Bhavani now.
Do you have any other idea for this patient?
Yeah, so for this patient who's young, just 22 and lean PCOS, instead of giving her letrozole 2.5 milligram for 5 days, I would rather give it for 3 days. Because with 5 days, she's just hyperstimulated with 4 follicles or 6 follicles. Rather, I would just give her less amount of dose and then see the response.
Okay, so this is also a new idea that if your patient hyperstimulates on a letrozole cycle, you can think of giving it for a lesser duration. Can be tried. Maybe I will try this in my next cycle with this patient.
Dr. Neeti, can we also try we start later on, because once we start on day 2 or 3, more follicles are recruited and more rapid growth. If we start later,
patient, maybe it will help because she has a 40-50 day. But you know what happens in PCO, that the follicular selection doesn't start only. So even if you start late, they are like day 2 only.
They will respond.
So PCOS on the day 7, day 8 also behave like day 2, right? So yeah. So what this we have partly discussed. So what do you do if you encounter thin endometrium on letrozole? Anybody? Thin endometrium on letrozole? Malvika, Dr. Malvika?
We have to be able to understand that there are no other causes for thin endometrium, right? So if we've already seen her in the previous cycles,
Yeah,
there should be
this we
no, we
discussed
have to
with
rule out other causes for thin
Dr.
endometrium.
Ruma's lecture also. I had asked her this question because when we give letrozole, we have this in mind that it will not have any side effects on the endometrium. But even with letrozole, we often find an endometrium which is 4 or 5 mm or 6 mm. It is not a very uncommon finding. So in
Yes.
that case, one thing is to definitely, as Dr. Malvika said, to look if there is no other underlying factor which is leading to a thin endometrium. But if everything is fine, then we remember that basically it causes a hypoestrogen state, and because of that, there could be a thin endometrium. And especially with a higher dose of letrozole if you are using, you can encounter a breakthrough bleeding also. So in that case, just as we continue with the monitoring. So this, I just 2 slides I have brought in where
And I think even with thin endometrium, many of these patients do conceive.
do conceive. Yeah, so this is one very interesting case report which I found where they had successful live birth on an endometrium of 3.8 mm. So even with in a letrozole induced ovulation cycle, this woman had a 3.8 mm endometrium. The clinician went ahead with a IUI cycle, and the patient conceived. So it was 3.8. And another study where it says that that in ovarian stimulation IUI cycle, this is not PCOS but unexplained infertility. They found that yes, it is true that there will be a higher live birth rate if you have a good endometrium. However, endometrial material thickness is not significantly associated with live birth rate when adjusted to treatment type. And applicable live birth rate are seen with all kind of endometrial thickness, even with less than 5 millimeter. So this is very important because I also have this, inhibition in going ahead with IUI when the endometrium is less than 6 mm in my practice. But the literature, suggests that you can even go ahead with a thinner endometrium with IUI. Thank you so much with this case also. So, Dr. Parul, please summarize the panel. Dr. Parul?
Yes, ma'am. Yeah. This is a ASRM recommendation 2020. This has already been discussed by Dr. Renu ma'am. So gonadotropin cycles should be managed by a clinician with requisite training and experience. And goal of gonadotropin treatment for ovulation induction is to promote to have a single mature follicle just to decrease the risk of multiple gestation and OHSs. And the risk of multiple gestation OHS cannot be completely eliminated with the use of gonadotropins. Patients should be counseled on the risk of ovulation induction with gonadotropins prior to cycle start. And this should be started at a low dose, like 37.5 to 75 units according to BMI, and cautiously increase as needed for the monofollicular development. And cycle cancellation, if more than 2 follicles is more than 16 mm, or if they 3 or more intermediate size follicle. And they have advised this recommend the luteal support in a patient with a hypothalamic amenorrhea, but the use of luteal support in a PCOS patient, there is insufficient evidence to make a recommendation. So to summarize, after diagnosing a PCOS according to Rotterdam criteria, first optimize the preconception health and lifestyle. First line medical management is a letrozole and increasing the dose maximum up to 5 milligram as required. So if the ovulation occurs, then you can repeat the cycles. If ovulation doesn't occur, then we go for the second line treatment like gonadotropins, in which the ultrasound monitoring and adjustment of the dose is required. And the second line treatment, that is another treatment, that is a laparoscopic ovarian drilling, that has become a less popular, and we do only when the evaluation of pelvis is required. So if we found the ovulation with the second line treatment, that is a gonadotropin, we can repeat the cycles. If no ovulation, then the third line treatment is the IVF.
Thank you so much. Thank you, our esteemed panelists. Thank you, Parul, my co-moderator. And we had a very interesting discussion here. Thank you so much.
Thank you, Dr. Neeti. It was such a wonderful and it's a big learning experience. These are real life situations that we are facing, and it is good to know what other people are doing. So thank you so much for putting up these very interesting out of the line cases of PCOS.
Thank
So
you,
somebody
Dr.
has,
Malvika, Dr. Renu, Dr. Shalini from the UP East chapter. Thank you so much.
Thank you.
And
there is a
who's-
question in the chat box, Dr. Neeti. I think
Yeah.
that's a good suggestion. Can we give estrogen from day 8 to day 14?
See,
You
in
are
our
talking
practice,
about thin ET.
yeah, thin endometrium. Actually, in our practice, we do not give estrogen. If someone else is giving, you can, opine on this.
I give, and I've seen good result. Estradiol valerate 2 milligram BT or TDS I have given, and I have got a good result in some of the patients. I'll not say in all. And I seen some prescriptions, although I do not use sildenafil in my practice, but I've seen some private practitioners giving sildenafil, and they claim that it gives a good result. I have no experience about sildenafil.
So I have to add one thing. When we are using a estrogen, especially in the clomiphene cycle or letrozole cycle, so receptors are already blocked. So there is no role of estrogen from outside. And
I've
when
seen
we are,
in my clinical practice,
yeah,
Dr. Parul,
yeah,
this is
Dr.
the
P.
theory.
Yeah,
But
I have also seen this use, but when we are seeing the increased size, maybe because the letrozole effect or clomiphene effect has gone. That
gone.
might have increased the
Exactly.
Letrozole
And
effect
Siddharth,
lasts for
when
only
the
2
effect-
days.
When the
So-
effect of the letrozole or clomiphene goes away after some time, the endometrium might pick up. But when the
Yes.
receptors are blocked, if you give exogenous estrogen, I agree with Parul that it might not
But
have
Dr. Neeti, we are talking about from day 8. So letrose action, if we give till day 6, it will go in 2 days. So the receptors are again free to act. So it does help, and I've seen it, and I've seen good response with estradiol valerate, although the evidence is not robust regarding this.
Thank you. Thank you. Thank you
Thank
so
you.
much. And now we will go on to this very important talk by Dr. Neelam Bapna. Dr. Neelam, are you there in a good setting now where you have a good Bhavani? Dr. Neelam?
Ma'am, I am not able to share screen from my side. There's some issue.
Acha. Dr. Neelam, are you there? Can you start sharing your screen?
Yes, yes. Yes.
Yeah. We are waiting for your talk, Dr. Neelam.
Yes, I'll start sharing. So am I audible?
Yes, Dr. Neelam.
Okay. So today's talk is on PCOS, adjuvants, the role of adjuvants in PCOS. Now, we know the definition and all, I'm not going into detail, but it is a complex interplay of hormonal imbalances, ovarian dysfunction, and metabolic disruptions. Why it is important to know the pathophysiology of PCOS before we talk on adjuvants, because we have to know what adjuvants do. It's a complex disease where the pathophysiology is still not properly understood. It may be because of hormonal imbalance in reproductive hormones. Insulin resistance is there, chronic inflammation is there because of some metabolic and reproductive dysfunction. And yes, some genetic and environmental factors also play a role in PCOS. So it is the role play of everything: genes, environment, and insulin excess, reproductive abnormalities, and yes, metabolic abnormalities. And this leads to the clinical presentation of irregular menstrual cycles, clinical hyperandrogenism, and polycystic ovarian morphology, which we take as a criteria for diagnosis of PCOS. So now, what is adjuvant? The word adjuvant is derived from the Latin word adjuvant, which means to hold. Hence, adjuvant is a drug or substance that enhances the efficacy of a primary drug. Although mechanisms of actions have been proposed, justification for the use of adjuvant therapies is usually empirical. There have been many studies, but they are all usually using it empirically. In PCOS, the role of adjuvants include the use of supplements, alternative medicines, lifestyle modifications, along with conventional treatments to improve symptoms of and overall health outcomes. Now, these adjuvants in PCOS, they enhance the treatment efficacy of the primary treatment. They can improve the fertility outcomes in PCOS patients. They may promote regular ovulation and chances of successful conception, may improve the quality of life by contributing to the weight gain, mood swings, and fatigue. They can address these symptoms and contribute to the improving the overall quality of life. They can address multifactorial nature of the PCOS. They can target various aspects of the pathophysiology like insulin resistance, hyperandrogenemia, and therefore provide a more holistic approach to the care. And also they may help in preventing the comorbidities of the metabolic syndromes by reducing the metabolic complications associated with PCOS, thereby help prevent the diabetes and cardiovascular complications. So various pathophysiological factors of PCOS for which we use adjuvants are ovulation induction, where most common cause is clomiphene resistance, insulin resistance, obesity, androgen axis, and metabolic syndrome. The various adjuvants used in the treatment of PCOS are lifestyle intervention, insulin sensitizers, anti-androgens, anti-obesity, nutritional substance, acupuncture, traditional and herbal medicines, cosmetic interventions, and for psychological aspects, we have cognitive behavioral therapy. Lifestyle modifications, as adjuvants in PCO, we all know the dietary changes, exercise, and stress management. They all help in elevating the negative impacts of PCOS, whether it be the insulin resistance or ovulation induction, or even the psychological aspects of the PCO. So usually the hyperinsulinemia is being treated by these insulin sensitizers in the form of metformin, myoinositol, and other insulin sensitizers which are recently used. And this hyperandrogenism, that is hirsutism and acne, these are being taken care by the anti-androgens in the form of spironolactone, flutamide, statins, and metformin, of course. And ovulation induction for infertility involves all these things. So the insulin sensitizers are mainly used as adjuvant for PCO patients, mainly for the treatment of infertility. The main drug that has come under so many studies have been done about the role of metformin. It improves the insulin sensitivity and ovulation rates. Additional insulin sensitizing treatments in PCOS include nowadays GLP-1 agonists, DPP-4 inhibitors, SGLT2 inhibitors, and PPARG agonists. These are additional insulin sensitizing treatments which have been studied in various studies recently for the role of their insulin decreasing the insulin resistance in PCO patients. And inositol, yes, it improves insulin signaling and reduces androgen levels. So mechanism of metformin is, yes, it inhibits the hepatic glucose production, decreases intestinal glucose uptake, and increases insulin sensitivity in the peripheral tissues. The clinical benefit has been shown to improve ovulation, menstrual irregularities, hyperandrogenism, and metabolic parameters. And women with PCOS, there have been several studies. And yes, it can also assist with weight management. It can help reducing the weight and reduce the risk of type 2 diabetes. And it is supported by a Cochrane review and multiple RCTs showing improved live births, clinical pregnancy, and ovulation rates. But yes, it has a side effect of increased gastrointestinal side effects. The various guidelines like ASHRAE and ASRM, they recommend restricting use to the women with glucose intolerance. But yes, other studies suggest broader use in combination with clomiphene citrate or letrozole to increase the ovulation rate. Now, benefits of metformin are that Endocrine Society recommends starting metformin in PCOS patients with diabetes or impaired glucose tolerance who fail lifestyle modification. It decreases progression from IGT to diabetes mellitus, and it also improves menstrual cycle, abnormal waist to hip ratio, and vascular markers in non-obese women with PCO. So they have this drug has a role in non-obese patients of PCO also. And it is considered as a second line of therapy for menstrual irregularities in patients with the contraindication for hormonal contraceptives. And it is also used commonly in adolescents as monotherapy, as it helped in restore normal menses, weight loss, and reduce insulin resistance. And it is also suggested as an adjuvant treatment for infertility. It helps prevent ovarian hyperstimulation syndrome in patients undergoing IVF, and it has shown benefits in obese patients. It increases the clinical pregnancy rates and improves the ongoing pregnancy rates in IVF. The ASHRAE 2023 guideline says that metformin should be considered in adult women with PCOS and body mass index of more than or equal to 25 kg per meter square for prevention of weight gain and management of weight and metabolic disorders. For adults with BMI less than 25, they say that it can also be considered, but the evidence is limited. Other drugs are like GLP-1 agonists like liraglutide and lexingitide. The benefits are weight loss, improved insulin sensitivity, improved ovulation rate in obese women with PCOS. They act by binding to the GLP receptors and stimulate glucose-dependent insulin release from the pancreatic islets. They have a longer half-life than our body's glucagon-like proteins, one because of the resistance to the degradation by the enzyme PPP4. So this is the mechanism of action. But as compared to metformin, weight loss and insulin sensitivity are higher with GLP-1 agonists than metformin, with fewer gastrointestinal side effects, but yes, it has high cost. And also the studies are limited with small sample size. Weight gain has been reported after therapy termination, and larger sample size and longer duration of these drugs are needed. Then DPP4 inhibitors like sitagliptin and alogliptin, they show potential in improving various metabolic and hormonal aspects of PCOS. They are suitable alternative for PCOS women intolerant to metformin and lifestyle interventions. How do they act? They decrease the degradation of incretins, therefore increasing the glucose-dependent insulin release, and also decreases blood glucose and visceral fat. And here also more studies are needed to validate findings and explore combination therapies for enhanced effectiveness. Another insulin sensitizing drugs are SL2TL2 inhibitors like empagliflozin. The benefits again are significant improvement in weight, BMI, waist-hip ratio, fat mass reduction. It also decreases the hyperinsulinemia and hyperandrogenemia in PCOS patients. The mechanism here is they act on the kidney via glycosuria and natriuresis, and therefore target the glucose reabsorption in kidneys. This is again a promising novel treatment for PCOS, but again we need more RCTs, long-term studies, and exploration of other SGLT2 inhibitors in PCOS to confirm the efficacy and safety. Another is this PPARG agonist. The most commonly used one is rosiglitazone. Again, the benefits are improved insulin sensitivity, lowered androgen levels, improved ovulation, and positive effects on the lipid profile. So these how they act, they usually improve insulin sensitivity by increasing insulin-dependent glucose disposable and decreasing the hepatic glucose output. They also lower the androgen levels. But the side effect is that the weight gain is there is increased risk of fluid retention, edema will be there is increased risk of bone fractures, particularly in the postmenopausal women, and therefore this is not being much used in PCO patients. Then next is inositol. Inositol is myoinositol and dipyroinositol. They improve the insulin resistance, serum androgen levels, and features of metabolic syndromes. The myoinositol part improves the oocyte quality, reduces the quantity of recombinant FSH needed, and decreases the days of stimulation in IVF cycles. How do they act? Myoinositol is involved in cellular glucose uptake and crucial for FSH signaling in the ovaries, while DCI plays a role in glycogen synthesis and restores normal insulin sensitivity by reducing circulating androgens. But here again, the role of inositol is not much understood. The data is limited and its use has been mostly applied as fertility treatment of PCOS or when metformin is not tolerated, given its fewer gastrointestinal side effects. So this is from ASHRAE 2023, already been discussed in our panel. So I'll not go in detail what they have told, but inositol could be considered in women with PCOS based on individual preferences and values, noting limited harm. And metformin should be considered over inositol for hirsutism and central obesity. So metformin can improve insulin resistance, decrease in free androgens, and increase sex hormone binding globulin. It can also reduce abdominal circumference and HbA1c, while inositol can decrease insulin resistance, LH-FSH ratio, and free androgen. So some studies have found that combining metformin and inositol can improve hormonal and biochemical parameters and have a significant effect on the menstrual cycle length. However, other studies have found no significant difference between the two drugs in terms of anthropometric parameters. So ultimately, treatment for PCOS should be adapted to the patient's symptoms and needs. So this was a meta-analysis in 2023 published, which included 7-8 studies, where the conclusion was that comparing hormonal and metabolic parameters between metformin and myoinositol did not show much significant difference, indicating that both drugs are equally beneficial in improving metabolic and hormonal parameters in patients with PCOS. In addition to insulin sensitizers, other pharmacological treatments like oral contraceptive and anti-androgens can serve as effective adjuvants. We all know the role of oral contraceptive pills. They regulate the hormones, improve the menstrual regularity, manage the hirsutism and acne by having their anti-androgenic effects of the progesterone, and they reduce the metabolic risk parameters in PCO patients. Another one are anti-androgens. We all know the administration can be done for moderate to severe hirsutism, and if there is mild hirsutism without adequate hair growth control after 6 months to 1 year of OCP use. So then we can use these anti-androgens in the form of spironolactone, flutamide, or finasteride. Spironolactone is most commonly used because it reduces hirsutism and acne and has also effect on the insulin resistance and other metabolic parameters of PCOS. But it can cause menstrual irregularity and can risk of feminizing a male fetus if pregnant patient uses it. These flutamide have high cost and there is a risk of hepatic toxicity, so not used much. And finasteride also is not much used. A role of statins. Atorvastatin is used primarily to lower the cholesterol levels. The benefits are that it reduces dyslipidemia and oxidative stress, decreases hyperandrogenemia, and improves lipid profiles. They act by mevalonate pathway, and therefore there is decreased production of other biologically important products of mevalonate pathway. Therefore, the decreased availability of cholesterol may result in lower androgen production and improves the adverse lipid profile. So it may worsen insulin sensitivity in PCOS. Individual risk assessment for cardiovascular disease is necessary before you initiate statins. Initiate statin therapy based on accepted criteria for cardiovascular risk and not solely on the PCOS diagnosis. Bromocriptine is a dopamine agonist. It restores normal menstrual cycles, regular ovulation in 30 to 60% of the PCOS patients. How do it act? It is a dopamine agonist, inhibit LH release, reduce LH pulse frequency, and thereby inhibiting dopamine's effect on LH release. So Some studies suggest that bromocriptine has little place in the management of PCOS, but some studies found that no hormonal measurement or response predicted the clinical response to treatment, and they should not be used in patients with coronary artery disease or other serious heart or blood vessel disorders. So usually its use is when there is hyperprolactinemia along with PCO. Now coming to the role of vitamin D, it has a role in calcium regulation, parathyroid hormone regulation that causes anovulatory infertility, menstrual dysfunction. The insulin secretion is decreased. There is hyperinsulinemia, obesity may be there, insulin resistance is there. And vitamin D influences cell processes beyond bone metabolism. They are included in cell proliferation, differentiation, apoptosis, immune regulation, and therefore they are implicated in reproductive health because vitamin D receptors have been seen in ovaries, uterus, and placenta even. So vitamin D deficiency is common among PCOS patients, and it is linked to insulin resistance, hyperandrogenism, and infertility. Deficiency may disrupt even the calcium homeostasis and parathyroid hormones, affecting the follicular development. So how do this act? It acts on the ovarian function, enhances the follicular development, luteinization, and FSH sensitivity. It normalizes elevated AMH levels, improving folliculogenesis, increases insulin sensitivity, and the calcium along with it, it also complements vitamin D in reducing androgen levels and improving overall health balance. Vitamin E and omega-3 fatty acids also show beneficial effects in managing PCOS. Now, cosmetic interventions, we all know it. I'm not going in much detail. Laser hair removal, electrolysis, or topical treatment in the form of ornithine decarboxylase on the skin can be given. Now, alternative therapies. There may be use of acupuncture that may help regulate hormones and improve insulin sensitivity. Herbal medicines have been tried in so many studies. They show, some herbs show promise, but more research is needed. And yes, there is role of probiotics and prebiotics. They may improve the metabolic profile. Now, acupuncture, a study with 17 overweight or obese PCOS patients showed that electroacupuncture for 5 weeks improved glucose tolerance and reduced adipose tissue androgens. And in PCO, it may help in regulating the hypothalamic pituitary ovarian axis, potential improvement in hormonal and metabolic profiles, especially in hyperandrogenism. So yes, it improves insulin sensitivity, reduces hyperandrogenism, and enhances the mood. But again, the need for robust evidence is there. Current studies are limited in size and scope. More high-quality systematic clinical and preclinical research is needed to validate the effectiveness of acupuncture. Now, gut microbiome research highlights significant differences in the gut microbiome composition between women with PCOS and healthy gut holes. Specifically, an increase in the harmful bacteria like Escherichia and Shigella and reduction in beneficial bacteria like Lactobacilli have been observed in PCO patients. So probiotics, they are live microorganisms that confer health benefit to the host. And it has been shown that the supplementation of probiotic have shown improvement in metabolic profiles in PCO patients. There may be significant reduction in weight, BMI, plasma glucose, and serum insulin level compared to placebo. Probiotics help balance the gut microbiota, which can positively impact metabolic and hormonal function. And prebiotics are non-digestible food ingredients that promote the growth of beneficial gut bacteria. So these also have positive health benefits, including reduced fasting plasma glucose and total cholesterol, along with increased HDL cholesterol. There may be improvement in the metabolic parameters in PCOS. Other novel approaches about gut microbiome are fetal microbiota transplantation, where in animal studies, fecal microbiota from healthy donor species to the recipient gut in the form of a capsule has been given. And this shows improved serum androgen levels, improved estrogen levels, and regulated menstrual cycle. Potential for significant impact on gut microbiome composition and associated metabolic and hormonal disturbances. Other approach is exogenous IL-22 administration, which is an immune factor. It is shown to reduce hyperandrogenism and insulin resistance. and improve ovarian morphology in murine models. So these two have been tried in animal studies. So, but they are future approaches can be there, helpful in PCO management. So current evidence is that prebiotics and probiotics have shown promising results in improving metabolic and hormonal parameters in PCOS. The FMT and exogenous IL-22 present novel approaches with potential benefits, though human clinical trials are needed to confirm their efficacy and safety. Herbal and traditional medicines as an adjuvant in PCOS, certain herbs like cinnamon, berberine, chestberry have shown potential in managing PCOS symptoms and improving metabolic markers, while traditional practices like Chinese medicine and Ayurvedic practices, along with acupuncture and lifestyle modification to address the multifaceted nature of the PCOS have been tried. These holistic approaches aim to restore the hormonal balance and the overall well-being of the PCO patient. But while herbal and traditional remedies may provide complementary benefits, it's crucial to ensure safe and appropriate use, as some may interact with conventional PCO treatments or may have some side effects. So, listing some of the herbal remedies, cinnamon, which is commonly used in Indian food, it decreases insulin resistance in women with PCOS. Several studies highlight its efficacy in improving metabolic markers and potentially aiding in weight management and menstrual irregularities. Flaxseed also, it is a phytoestrogen which is rich in ligands, which are phytoestrogens that may help in balancing the hormones and lead to significant reduction in BMI and weight loss. And it may also positively affect the lipid profiles and insulin sensitivity. Then chestberry, it lowers the prolactin level, improves menstrual regularity and treat infertility. But again, evidence is less robust, but supported by both clinical, preclinical and clinical studies. Others are licorice, which leads to reduction in testosterone, can be used in an adjuvant therapy for managing hirsutism, but long-term use can have potential side effects such as hypertension and hypokalemia. Berberine also improves insulin resistance and dyslipidemia in PCOS patients, more effective than metformin in some studies, particularly in reducing the androgen levels and improving the LH ratio. Nicobene also has anti-androgenic and hypoglycemic and anti-inflammatory role. The phytochemicals like curcumin, lutein, fiestine, etc. may offer multiple benefits. They reduce the testosterone level, improve LH ratio, enhance the insulin sensitivity, reduce the oxidative stress, and also have anti-inflammatory effect. Many of these effects are supported by both preclinical and clinical studies, while the current data is promising. Further studies with larger sample size with varied dose and longer duration are needed to confirm these findings. Then flavonoids. These are a diverse group of plant compounds known for their various biological activities. They also decrease testosterone levels, improve insulin resistance, and increase the expression of IL-6 to treat PCOS. And several of these flavonoids are resveratrol, hesperidine, etc. They are also, animal studies say that research on PCOS-induced rats have demonstrated that flavonoids can effectively reduce the testosterone level, improve insulin sensitivity, and reduce ovarian cysts. And human studies, while animal studies provide promising data, further clinical trials are needed to validate the effectiveness of flavonoids in human PCOS management. Now, these are some other these other compounds which we usually use in our Indian food. I'm not going into detail. Now, about N-acetylcysteine in PCOS management, it is an amino acid derived from cysteine and it is acylated form of both the amino acid L-cysteine and reduced form of glutathione. It also has antioxidant property, insulin sensitivity, it improves by insulin signaling pathways. It leads to help regulate menstrual cycle by modulating ovarian function and hormone levels, and it also reduces the androgen level. So it can be used as a supplement to increase fertility, improve ovulation, and improve lipid profile and insulin resistance in women with PCOS. So overall, in comparison with metformin, administration of N-acetylcysteine as a supplement to clomiphene can improve the hormonal profile and hyperinsulinemia and regulate homocysteine. Then chromium picolinate. This was a study in 2017 where chromium supplementation and polycystic ovarian syndrome was done by a systematic review and meta-analysis. The conclusion was that this chromium picolinate supplementation has beneficial effects on decreasing BMI, fasting insulin, and free testosterone in PCOS patients. Another drug is melatonin. Melatonin leads to poor sleep, can cause menstrual dysfunction and reproductive dysfunction in PCOS patients. So melatonin supplementation can help to improve sleep and oocyte and embryo quality, the number of new immature oocytes, and production of progesterone from the corpus luteum, and fertilization and pregnancy rates may be improved in PCO patients. And even melatonin and inositol, they can be used synergistically to enhance the oocyte and embryo quality and improve the ART outcome in PCOS. So this was the review. Sorry. There it says that based on the data included in this review, it was found that administration of melatonin can improve the oocyte and embryo quality in PCOS patients. It may also have beneficial effects in correcting the hormonal alterations in PCO patients. Since metabolic dysfunction is a major finding contributing to initiation of PCOS, melatonin can hinder the process via its improving effects on metabolic function. So its role has also been studied a lot. Then coenzyme Q efficacy was also, there are so many papers. A systematic review and meta-analysis showed that based on the current evidence, it could be considered that addition of coenzyme Q10 is safe therapy to improve PCOS by improving insulin resistance, reduce HOMA-IR, FINS, FPG, increasing sex hormone levels, increase FSH, reduce testosterone, and they also improve the blood lipid profile. So this coenzyme Q also has a role in PCOS. Then cognitive behavioral therapy for depression in women with PCOS, systematic review and meta-analysis showed that most psychological interventions applying CBT are effective in lowering depression scores in women with PCOS. These results should be interpreted with caution due to the methodological differences in quality of studies. And here also they say that more clinical trials are needed to assess how many sessions of CBT are necessary to treat depression in women with PCOS. So all these were the adjuvants in PCOS, but the challenges and limitations in the use of adjuvants in PCOS are because PCOS is a complex and heterogeneous condition. Therefore, it makes it challenging to find a one-size-fits-all adjuvant approach. So we have to individualize treatment according to the patient profile. Then we have limited long-term data about all these adjuvants. So safety and efficacy data are limited, and therefore it makes it difficult to assess their impact on long-term outcomes. Then adherence to adjuvant therapy can be challenging for PCOS patients. Long-term use, multiple medications, and potential side effects contribute to compliance issues. Again, cost consideration may be there. Some of these are quite expensive, making them inaccessible for some patients. Then there is lack of standardization. Adjuvants in PCOS management lack standardized guidelines for doses, duration, and combination therapy, and this leads to variability in treatment outcomes. And they may also interact with other medications commonly used in PCOS treatment. So therefore, careful monitoring and potential adjustments are necessary. So what are the emerging research approaches and future interventions in PCOS? There may personalized approaches, tailoring adjuvant therapies based on individual patients' characteristics so as to incorporate and also incorporate genetic factors to optimize treatment outcomes. Nutraceuticals and herbal supplements, we need more increasing research on these compounds like myoinositol, omega-3 fatty acids, and berberine. And these adjuvants can be used if we study more about them. Integrative approach where we combine traditional herbs and traditional medicines along with the routine primary treatment like acupuncture, yoga, and mindfulness. Telemedicine and digital health, like to monitor patient progress, can be helpful. Then novel therapeutic targets involved in PCOS pathogenesis to identify adjuvant interventions beyond traditional insulin sensitizing and anti-androgen agents. So we are working on novel new therapeutic agents. And yes, preventive strategies are always helpful. Develop some early screening and intervention programs to identify and manage PCOS risk factors before the onset of clinical symptoms and complications. So to conclude, effective management of PCOS requires a comprehensive, evidence-based approach that incorporates lifestyle modifications, targeted pharmacological interventions, and a personalized treatment plan involving use of appropriate adjuvants. Thank you.
Thank you so much. It was a very comprehensive on adjuvants, and you even touched upon things like cognitive therapy and acupuncture. It was very interesting to listen to you, Dr. Neelam. Thank you so much. And I'm glad we could finally listen to you, because probably you were not in your office when you called.
No, I was out of Jaipur, and I was searching for a good this thing. I had to for emergency somehow. I had to come to out of Jaipur. So I took my laptop also, but the network was not working.
No, this was working well wherever you were. Thank you so much. Dr. Malvika, are you there? Dr. Malvika?
Very
a
much.
vote of thanks. Yeah. Dr. Malvika, you can give a vote of thanks to everyone.
So I would like to congratulate Dr. Neeti first for organizing such a comprehensive webinar today on PCOS, which is a very important topic. And I would also like to congratulate all the speakers and the panelists and chairpersons for being there. And it was a very comprehensive and a long webinar, and we had good attendance also. So thank you very much, all of you, the audiences, and the technical people also, Shivam, who was there to support us so that we could, be present for the webinar. Thank you.
Thank you. Thank you, everyone. Thank you.
Thank you.